Hello, hello, my friends. It's Jill Osborne from the Interstitial Cystitis Network. I'm a wee bit late. I'm sorry. I'm about 10 minutes late starting the stream. I had to drive 40 miles this morning to go deliver a birthday present for a 6-year-old. I couldn't miss it. I had to do that. So let me just make sure everything is functioning. There we go. Hello, hello, hello. Clean up my background. All right. My name is Jill Osborne. Hello, Paula. Thank you for your patience. Sorry it took so long, but like I said, I had to make a quick drive this morning to go deliver a birthday gift for a 6-year-old. So I had to do that. My name is Jill Osborne. I am the president and founder of the Interstitial Cystitis Network. I'm the longest serving IC support group leader in the world. I want to do a sound check really quick. Paula, how is the sound? Is the sound okay? Is there an echo? Hello, YouTube, you guys. I need you to do the same thing. Can we do a sound check? And can you tell me if your sound is okay? What's going on with my mascara there? I've been running. Are we dealing with good sound or are we dealing with echoes? All right. All right. Excellent. Yes. Yes. We have been having absolutely wicked storms here in California. So we're in a little bit of disarray. Tons of thunder and lightning, as you guys are so well known to. We don't normally get that. Very, very cold weather, all that sort of stuff. Hello, Anne. It's nice to see you, my friends. Right now, we are streaming on 2 platforms. We are streaming on YouTube and Facebook simultaneously. Normally, when I do these meetings, we will go anywhere from 2 hours to 5 hours. It just depends upon how long you guys have questions for me, because I am always, always happy to take questions. Normally, when I do these meetings, I have a little intro that I like to do first, some new content that's meaningful. And boy, do I have content for you today. Holy moly, I was working my tush off this week writing articles for our magazine. So I've got some content, and then we're going to take questions. But Anne has a quick question. Oh, thank you, Anne. If leukocytes on azostrip are positive, is it a UTI? No, it's not. Not necessarily. It's the nitrites that indicate the positivity. Leukocytes, not so much. Leukocytes can happen just when the bladder wall gets very, very irritated. The body sends your natural army, your white blood cells, to the area to make sure that there's no infection, because the job of those leukocytes is to kill infection. But what happens is, as the leukocytes swarm the area, they get released into urine. So it's very normal to have leukocytes in your urine and not nitrites with a bladder wall flare. Just happened to me recently, as a matter of fact. All right, let's see here. So I shared last week that I ended up in the ER again. It's like my home away from home. I mean, legit, that's what happens when you've had major surgery like I've had. I happened to get very, very dehydrated, and it was glorious weather, and I was just out in the sun, and I was an idiot, and I didn't drink enough, got really, really dehydrated. And what we found was that my potassium was really low. And so they gave me potassium. And you know what? That burned my bladder like a son of a bitch. I felt like I had a UTI for 2 days. And so I had my azo strips out, and I was like testing my urine too, and I was positive leukocytes, I was negative nitrites, and then the light bulb turned on. It's like, Jill, they gave you potassium. We know that potassium can irritate the bladder wall, even in patients who don't have IC. Okay. Years ago, we had what we called the potassium sensitivity test. That was a diagnostic test. The theory is if you put a salt solution of potassium into the bladder wall, if there's a wound in the bladder's going to scream. So they were using that as a diagnostic test for IC. The problem is that you put a lot of potassium in in a postmenopausal woman's bladder or somebody else with any minor bladder issues, their bladder is going to scream too. So potassium is not a diagnostic test for IC. That has been thrown out as a diagnostic test for IC because potassium basically hurts everybody. Susan said, I went to see the urologist who's new to me and she scheduled cysto. When I went to the office, she was ready to do a cysto with a rigid catheter metal, not a flexible one. Without anesthesia, I was ready to walk out. I did this, and I did. Is this how cystoscopies are done today? Well, yeah. I mean, listen, a cystoscopy is what I call a looky-loo. It's a quick way to look into your bladder. They just numb your urethra, stick the scope in, take a quick look, pull it out, you're done. The only anesthesia that's done is at the urethra. A flexible cystoscope is a newer equipment that a lot of clinics just don't have. So, I mean, so you walked out, you know, I listen, I like data. I like facts. And there comes a point in time when if you've been in pain for a period of time, it's important for them to look in your bladder because we don't want to guess. We need facts. And I was working with a patient this week who, God, her symptoms were insanely severe, like really, really severe. And of course, she was doing a lot of things that she shouldn't have been doing, like drinking, how many cups? 3 cups of coffee a day and other things like that. But she refused to have a cystoscopy. And I'm like, why? Why would you refuse if you've been in pain for a long period of time? We want the doctor to be able to look at that tissue. Because as I said to her, the pain you're in is so severe, it really sounds like you have a Hunner's lesion. It's important to let them look and let's just see if there's anything there that's funky, right? So a plain cystoscopy that's not a hydrodistension, definitely done in the doctor's office. It is a very, very, very quick test, like 5 minutes in and out. No big deal. If my doctor wanted to do one right now on air streaming, I would do it. A cystoscopy does not scare me at all. Okay, at all. Now, if on the other hand, she was proposing to do a hydrodistension also, where they fill your bladder with a lot of fluid and stretch it out, I would have definitely backed out and said, no, you're not doing that unless I'm under anesthesia, for sure. Hey, listen, I forgot to get a glass of water. Give me a quick sec. I got to go get a glass of water. Be right back. All righty, my friends. I try to drink 3 of these a day. I really have to work on not compromising my hydration. Okay, so Facebook, can you see me on Facebook? My screen has frozen on Facebook as it frequently does. Can we just do a check-in on Facebook? Is everything okay? Can you guys see me okay? Because this is just what Facebook does. Good. Thank you, Susan. Okay. So, hey, we're going to talk about something brand new that we've never talked about before. This is something that I had really never heard of until early last week. It's called post-UTI hypersensitivity syndrome. Okay, so how many of you have had what you thought was a bladder infection, or in fact, it really was a legit bladder infection confirmed by testing? They treat it, antibiotics, your urine is clear, the bacteria is gone, but you still feel like you have a UTI. You are still running to the bathroom, you are still getting up at night. Everything is saying to you, I still have an infection, except for the lab results. The lab results say, no, you really don't. So, earlier this year, not long ago, some new research was released, which found, and let me just pull up this study here. Hold on a sec. So I already have a blog on this on the IC Network website. For those of you who get our newsletter, I sent out a free IC newsletter last night to 35,000 IC patients. So make sure you sign up for the IC Network newsletter because, hello, it's free and it's a great way. Hi, Debbie. Hi, William. Yeah, hold that thought, William. Okay, so why do I still feel like I have a UTI? This is absolutely heartbreaking because so many patients ask this question. Clearly something is wrong, but it's not infection anymore. So think about it. Here's what this study found. Researchers studying patients with lingering symptoms after UTI have discovered that the bladder itself undergoes significant changes during infections. So during a UTI, your body is fighting very hard. Infected bladder cells are sloughed off and shed. The tissue in the bladder becomes very inflamed. And part of that process is that nerves get damaged. Dr. Byron Hayes explained, typically during every bout of a UTI, epithelial cells laden with bacteria are sloughed off and significant destruction of nearby nerve tissue occurs. These events trigger a rapid repair program in the damaged bladder that also involves a massive regrowth of destroyed nerve cells. Sounds good, right? It sounds like, of course, anything we can do to heal tissue is good, but sometimes there are unexpected results. So as the bladder heals, nerves regrow, but for some of us, more nerves grow back than you originally had, and they become overly sensitive. So this means that the bladder starts sending pain and urgency signals even when there is absolutely no infection again. So simple things, just like urine touching the bladder wall, can feel irritating or painful. Sounds a lot like IC, right? It does. But another key piece of this puzzle involves mast cells. Now, of course, mast cells are commonly associated with allergies. When mast cells get provoked, they release histamine. And that can cause redness and irritation and all that sort of stuff. But mast cells and nerves have a lot of what we call nerve crosstalk. So when mast cells get involved, they increase inflammation, they increase sensitivity, and they also increase nerve growth. So this again results in a bladder that feels like it's infected when it's not. So what is this called? This is called post-UTI hypersensitivity syndrome. It's incredibly difficult to diagnose, and for many of you, it's very, very difficult to accept. I mean, that makes sense. You feel legit like you've got an infection. But in fact, you have to remember, I mean, think about it this way. And so when I was young, we had a lot of old timers, old World War II vets, who would all sit in groups, and when a storm came in, they'd start rubbing their knee. They're just, oh my gosh, the storm must be coming in. My knee hurts. Why did that happen? because at some point in time, that knee sustained an injury. So a bone might be broken, a muscle might be torn, but every injury also involves nerves. And so the bone heals, that's good. The muscles calm, that's good. But what about the nerves? What happens to the nerves after an injury? That's the critical question here, because nerves that are injured often become very, very sensitive. And that, in essence, is what this study has found, that during a bladder infection, not only are nerves damaged and cells are damaged, but the healing process ends up provoking yet more nerve sensitivity. So how do we diagnose this? It's not really a test to diagnose it. I mean, it's really about, if they don't find infection and yet you still have symptoms, we have to consider the fact that perhaps your nerves are irritated. Who is most at risk? People with recurring UTIs, people who have very severe infections, or people who have repeated inflammation of the bladder. And so what do we do? What do we do when we have this? Number one, it's all about creating an environment that will help this tissue heal and help calm the nerves down. We have to calm the nerves down. How do we do that? Number one, we don't provoke the nerves more. We don't irritate the tissue more, because the more you irritate it, the worse it's going to get. And so this is going to be following the IC diet, not for the rest of your life, but like for 3 months, we got to help that tissue heal. And you cannot cheat. If you have a cup of coffee once a week, you're destroying an entire generation of cells that are trying to heal your bladder. The bladder is the slowest healing organ in the body. It takes a lot of time to heal. There was a recent study that said it could be as much as 6 months for the bladder to completely heal. So we don't want to provoke the nerves more by scouring the wound or injury or damaged cells with acid. And number two, I mean, like seriously, we don't want to do anything that's neuroinflammatory like coffee, like caffeine. Got to back off on the caffeine if we want the nerves to calm down. We also want to think about, are there any other things in your life that could be irritating the bladder wall, like exposure to secondhand smoke or smoking? You know, all those toxins in cigarette smoke, they end up in your bloodstream, they end up in your urine, where they are profoundly irritating. We have research to show that children who live in the home of a smoker can have all the symptoms of IC because their bladder is being irritated and damaged by the secondhand smoke. So backing off on the smoking, I'm sorry, I know, I mean, I'm not telling you what to do. I'm just helping you understand the things that can provoke your bladder. This is where a medication that can calm nerves might be very helpful. Now, from a supplement standpoint, the very first thing you could try is palmitoyl-ethanolamide, also known as PEA, in which there are dozens of research studies that show it has a nerve calming effect. So that would be, you could try Peora, or you could try P-Leaf, which is still on sale, 30% off on Amazon. Again, the goal here is to calm nerves down. If this doesn't work, then you could go to something like gabapentin or amitriptyline. You could. That's reasonable. The second thing we want to do is you want to calm mast cell activity in the bladder wall. So especially if you have a history of allergies or asthma, there's a whole nother research study in that too. Ooh, remind me, I got to talk about that. So doing an antihistamine like hydroxyzine or a supplement that contains quercetin can be very, very good. And of course, this is where we want to try to protect this damaged tissue. And this is where Elmeron would have shined were it not now associated with such severe, devastating side effects like blindness and inflammatory bowel disease. But you could, for example, do a rescue installation with heparin to coat the bladder, or if you're in Europe, Ioloril, which is a chondroitin hyaluronate coating of the bladder wall, something that will cover these irritated nerves, these irritated cells, to protect them from urine. Or you could go ahead and try one of the chondroitin supplements like Bladder Builder or Bladder Rest. But here's the thing I really want you to understand from me. This is not in your imagination. I mean, we got to get real here. How many times have you gone to the doctor and the doctor hasn't found infection and they look at you like this is all in your head? You know that happens. That's happened to me. That happens to almost every patient at one point in time. With this new research, is saying you are not imagining this at all. You are not overreacting, and you are absolutely not alone. Your bladder is still healing from the damage of the infection, and the healing process can leave your nerves in a hypersensitive state. And understanding this is a turning point, because once you stop chasing the infection that really isn't there, you can finally begin to treat what is. Now, if you doubt it, if you doubt what I'm saying, if you doubt that you don't have infection, I always say, okay, prove it. You can have a next generation DNA urine test, 100%. You can do that. I encourage you to do that. Listen, I've worked with patients for many, many years. I'm telling you right now, you are wise. So many of you really understand what caused your symptoms and what they are. If you believe in your heart of hearts you have infection, have a next-gen test. And let's see what that finds. If the doctor is saying your cultures are negative, you got to remember cultures only grow out the bacteria that eat the culture medium. They miss a lot. Next-generation testing does not miss a lot. You can have that next-gen test. And if that comes back positive, maybe you've got a fungal infection, a candida infection, or a really rare, unusual bladder infection that a culture would have missed. Man, you got all the ammunition you need to go get your antibiotics. But if that next-generation test finds nothing, then you have to accept and understand that you really don't have infection, that there's something else going on. In many cases, it's nerves that are very, very inflamed, but it can be other things too. And this is why we phenotype. Because if we phenotype, we're trying to understand underlying causation. We're trying to understand the underlying problem. Now, here's another research study that came out. You know, there are a lot of people that are saying IC is an autoimmune disease. Right? There are doctors that are saying that. There are patients that say that. And they make these kind of grand statements that it's all driven by an autoimmune process. We have another new research study that specifically looked for that. And it studied Sjogren's syndrome and lupus and all the rheumatoid arthritis, all of the autoimmune conditions that we know, we call them AIDs, to see if there was a genetic connection between those and IC. And guess what? There wasn't. And this is a really big, robust study. So that's another big part of IC that we can now throw away. Now, is there a small subset of IC patients who have an autoimmune dysfunction? Probably, maybe 5%. I just wrote an article on lupus cystitis. Lupus is an autoimmune disease that affects the bladder. Many lupus patients are misdiagnosed with IC. They try all the IC therapies. Nothing works for them because fundamentally their problem is that their body is attacking itself. And thus we've got to do very specific therapies, usually steroids, to try to calm that process. So anyway, big research week. Here, I got to turn my heater on. Hold on. You can always tell when I'm writing our magazine because I'm like nose deep in the latest research. All right, here, hold on one sec. Okay, so I can minimize that. Oops. Okay. Is there any other big scientific research happening? A little bit. I talked a little bit about it before. We have new research that has linked bladder. Has linked eye damage and eye damage to bladder installations of Pitocin, also known as Elmiron, and/or injections. That's also the other really big thing. We'll be doing a patient registry. If there's anybody out there who's been damaged by Elmeron or Pentosin, would you please send me an email, icnetwork@mac.com, so that I can include you. We have a very special support group for patients who are in this group. And we are meeting once a month by Zoom. We have a number of patients who are dealing with devastating eye issues, including blindness, as well as having to have their bowel removed. Okay, so listen, you guys on YouTube, you're not saying anything. I see you. You give me questions. All right, please give me questions. All right, and for those of you on Facebook right now, let's go through some of your Facebook questions. And just so you know, on Facebook, my screen has frozen, so I can see your I can see your questions, but I can't see anything else. And Facebook is notorious for doing this. So hold on a sec. So let's go back. Did my heater turn on? Oh. It did not. It did not. I'll have to go get it. I'll have to go get a sweater. All right. So let us see here. Now, here is my approach to my life right now and doing these meetings and phone calls. Be the squeaky wheel. I am often completely hammered by phone calls and messages. If you call me and I don't answer, I will text back saying, can I call you later? Or I can't talk now. That just means I'm already working with somebody. And so just be patient. I will call you back when I can. Feel free. You have my permission to call me a couple of times a day or a couple of days in a row. It's okay. And the same is true with email. Please feel free to email until you hear from me, or better yet, pick up the phone. And the same here is with questions. If you ask a question and I miss it, ask it in. Don't take it personally. The hardest part about doing a stream is Facebook moves very, very quickly, and I just can't see them. Sherry says here, I'm having a pelvic floor flare. I've been drinking low acid coffee. Do I need to stop? Yeah, probably. Probably, because when your muscles are tight, that restricts blood supply to your bladder, and your bladder wall is vulnerable. So I would back off on the low acid coffee right now. You need to be doing things that will relax that pelvic floor. And if you don't have it yet, whoops. Sorry about that. We have our flare guide, the IC101 flare guide, which has a whole bunch of things that you can do for a pelvic floor flare, including stretches and all sorts of things like that that can relax it. It kind of gives you an hour by hour rescue plan. So the IC101 flare guide is good. But most of all, we've got to think about how can we relax these muscles. And so if you have a wand, you might want to do some internal work to see if you can find the muscle that's tight and relax it. If you have a muscle relaxant like Flexeril or Baclofen, there are moments in time when a muscle relaxant is very helpful. If your doctor has given you a Baclofen or a Valium vaginal suppository, that's something that you can use to relax those flares too. Okay. You're welcome, honey. You're welcome. All right, Facebook. William said, that's my life living with Hunners. So, William, what have you done for your Hunners so far? And have they, number one, how many do you have? Number two, when were they last treated? And number three, how were they treated? That's what you want to know. And just know we now have some new research that shows that lactoferrin was quite good at healing Hunner's lesions and making red inflamed bladders pink and healthy. So we now have an over-the-counter supplement with a good solid study showing it can help Hunner lesions. Hello, Debbie. Pamela says she needs a newsletter. Just go on over to icnetwork.org. And there's a pop-up window that will come up where you put your email address in. Hello, Kathy. Nice to see you. Debbie says, I always feel like I have a UTI. I bet everything my firstborn, my home, but it comes back negative. I'm so sad and confused when it's not. So that's a sign that maybe we're dealing with really severe nerve inflammation instead. So you just have to remember that an infection is damaging. It's very, very damaging because bacteria burrow into cells, destroy the cell, turn it into it. Well, it basically turns it into a bacteria factory. So the cell fills up with bacteria and then it ruptures open and it releases the bacteria. And so what happens with a bladder infection is you end up with kind of a tunneling effect. So if we look at this picture here, so here are the urothelial cells that would be infected. So an infection might start here, and then this is going to rupture, and now the infection is going to go here, here, and maybe here. And then these are going to get infected. And so now this next layer is going to get infected. And so you end up with like physical tunnels of damage in the bladder wall. But it's not just the cells that are damaged. We get mast cells involved and we get nerves involved. And that's what perpetuates this bladder wall sensitivity. I know you're sad. You're so sad and confused when it's not. Yeah, because it'd be really nice if we could just take an antibiotic and make it all go away. But one of the things that you learn as you get older is that injuries happen. And a big part of any injury is a lot of nerve sensitivity. It just is what it is. And so I have a lot of nerve sensitivity in my body right now. And one of the areas of my body, now remember, I have no shame. I will talk about anything. I double dog dare you to try to embarrass me. I will tell you remember, my symptoms started, I had my first urinary symptoms at the age of 13 after I broke my tailbone badly. 100%. I could move that tailbone, that fractured piece of my tailbone around with my finger for about a year, which I did. The legacy of that injury was very, very, very tight pelvic floor muscles. They were so tight they had to dilate my urethra so that I could pee. But nerve sensitivity was also big and continues to be big for me. And the most sensitive part of my body is actually my rectum right now. It's just, I feel anything that's in it. And that's just part of that old injury. And so I'm very, very invested in having good bowel hygiene. But vulvodynia, skin sensitivity, smell sensitivity, having a wicked sense of smell, visual sensitivity, hearing sensitivity. It's amazing what happens when nerves get irritated. And the other great thing is that nerves talk to each other. So one of the big questions several years ago was, why do so many IC patients also have IBS, kind of bowel sensitivity? And they were studying nerve pathways. And so what they did is they introduced radioactive markers into the bladder wall and also into the bowel. And they followed this radioactive markers as they moved through the nerves. And so you got A here and you got B here. One's coming from the bladder, one's coming from the bowel, and they're going closer and closer and closer as those nerves are going up to the spine. But you know what happened? At the spine, they met. And those radioactive tracers ended up in exactly the same nerve root. We call this nerve crosstalk or neurocrosstalk. So what does that mean then? That when the bladder gets irritated, that irritation goes up to the spine, and then it affects the other proximal nerves, so it can go back down to the bowel. And the same is true with the bowel. When the bowel gets irritated, that's going to go up to the spine, and that can go back down to the bladder. Neurocrosstalk. We call that the pepperoni pizza algorithm. So when they irritated the bowel with pepperoni, some of those patients also had bladder irritation, and that's just from neurocrosstalk. It's crazy. All right, hold on a sec. See, there you go, Facebook, moving fast. Okay, hold on. William said he's had fulgurations. Joanne said Facebook has frozen only for me. What happens for me as a streamer is that it won't show me my face. It won't show me talking. Right now it's showing an empty chair. It just does that randomly. Judy said, this is my story. Like you broke your tailbone at 13. Oh, Joanne says the picture has frozen on Facebook. And yet William says it's not frozen for him. Okay. Welcome to life on Facebook. Baffling. Okay, so hold on a sec. I got to go back up. Okay, you guys on Facebook, don't write anything for a moment because it's making it hard for me to read. Just hold tight. Julie says, I'm 61. Mine is getting much worse. Should I be on a supplement of some kind? Trying to follow the IC diet. I do have tremendous stress. Okay, Julie, not only do you have tremendous stress, you have estrogen atrophy. And that affects your bladder. So as we get older, our body starts we don't have the estrogen we used to have, which means that our bladder can't make that nice, thick, protective mucus that normally protects the bladder wall. And so you're starting to get drier. So the bladder is like your mouth. It's a hollow organ that's wet and slippery on the inside. And the purpose of that moisture, the purpose of that mucus is to act as a thick protective barrier. And you can see it here. It's not really blue, but there is a nice thick coating of mucus that sits on top of your bladder. And you can see that when it's there, it pushes urine away from these more fragile cells. Unfortunately, mucus production is estrogen dependent. What that means is that your body needs estrogen to make mucus. If you don't have the estrogen, your body can't make the mucus. It's just that simple. It's that simple. So what that then means is that your bladder's ability to defend itself is now compromised because it just doesn't have that nice thick protective coating anymore. So that's probably why your symptoms are getting a bit worse right now. And so diet for you is really, really important. That cup of coffee you drank in your early 50s, you might not be able to drink in your 60s. Your bladder just doesn't have the resources to defend itself. So I'm glad you're doing the IC diet. That's really wonderful. But the next thing we have to ask is, are you using any estrogen? We need an estrogen product. Because when you give that skin estrogen, it immediately plumps up and starts to make mucus. And so you want to have your doctor look at your skin. If your vulva is dry and your vagina is dry, so is your urethra, so is your bladder. The most important treatment for that is, in fact, topical estrogen, not oral estrogen, not systemic estrogen. I'm talking estrogen you just put on the skin. That's what we want, estrogen you put on the skin. Now, for some patients, that's enough. That was enough for me I'm 65 now. I did, that's still what I do, but I will say I'm now getting to the point where I am definitely feeling a little bit more dryness in my vagina and in my bladder, even with my estrogen. And this is where using a supplement could potentially be helpful. Using something that contains chondroitin coats the bladder wall, protects the bladder wall. So you can see in the background there, Bladder Builder. Bladder Builder is our absolute favorite supplement. I actually helped to design it years ago. It has chondroitin for the bladder wall, quercetin to reduce mast cell activity, but most importantly, it also has PEA in it to calm nerves down. So there are 4 supplements that are commonly used. You can use Bladder Builder. You can use Bladder Rest, which is kind of a simple formula for people who are very sensitive. You can use Cystomend or Cystoprotect. Those are kind of the top 4. And there are a lot of supplements on Amazon, including those supplements that say they're good for bladder health, but you got to be really careful because a lot of them have ingredients that are more acidic. Any product that's for UTI, don't use because you don't have a UTI. You've got freaking dry skin. So those are generally not going to be helpful. What's going to be helpful is a chondroitin-based supplement. Donna says she got a letter from Heather's Tummy Fiber. The company is having financial problems. Yes, they have been. Did they say they were going out of business? They haven't told me they're going out of business. What happened with Heather's tummy fiber is Heather's tummy fiber is for patients who have irritable bowel syndrome. Heather, who started that company, is a peer of mine. She started her company when I started the IC Network. Man, that woman knows her stuff. You should sign up for her newsletter if you've got IBS. I read it. She says that every day, a little factoid every day, and it's brilliant. She's on the mark with her knowledge and insight about IBS. The problem is that her acacia fiber comes from Africa, where there are wars, big time wars, and they just can't get the certifications and the professionals to go in and inspect the fields because it's a war zone. So they're really having a tremendous problem getting their product right now. I hope that they don't go out of business. I love them. I love what they do. She taught me so much about IBS. It was very, very helpful. But I haven't received a letter from her. You know what? Let me just check my email real quick. Hold on a sec. Because she would tell me for sure, since I'm a reseller. No, I don't see any notices about it. Okay. Her website's helpforibs.com. You can find Heather's Tummy Fiber in the IC Network shop. We sold it for like 20 years. It's a win all the way around. It's too bad that that they're having so many, that we are all having so many problems right now with warts in this country, in this world. Jeannie said, every time I have these flares, I run to you so I can remember what to do so I can improve my symptoms. Thank you. So Jeannie, you don't have to run to me. Just get the flare guide. This is everything I know about flares, you know? I wrote the very first flare guide 10 years ago. So, and this was a massive update. Anne says, if a culture has a trace of bacteria, is it a UTI? No. Okay, so that was another thing, because I'm doing yet more research on a new type of next generation DNA urine testing. And I've been going through a lot of the research that they've given me. And really, there is a concept called, colonization versus infection. Colonization versus infection. So when you get a urine test back and there are small quantities of bacteria and you have no symptoms, then that's a sign that your bladder is just normal and it just has a normal quantity of diverse bacteria growing in it. The key point is your symptoms. If you have a small amount of bacteria, but you are showing symptoms of an active infection like fever and pain and frequent urination, that's when we look at those results a little bit more carefully. Women, and for men, I don't have this research for you. I am sorry. I just don't have this research for you. But for women under the age of 45 have a very modest population of bacteria. Women over the age of 60 have a ton of bacteria living in there because our biome has changed with age. It has become much more friendly to bacteria, but that doesn't necessarily mean they're infectious bacteria or that they become infected. We have 70 trillion bacteria living in our body. If we didn't have bacteria, we would die. Bacteria help us to digest food. They help create food that nourish our cells. Bacteria is vital to our long-term health. And so there's always going to be a colony of bacteria that live in your bladder regardless. Donna said they're possibly going out of business. They're asking for donations. Yeah, I know. I saw that. And I did give her a $200 donation. So what would I recommend in place of Heather's tummy fiber? Any Soluble fiber. My go-to is actually eating peas, green peas, and garbanzo beans. Those are both soluble fiber, easy on the gut. They'll give you plenty of fiber. Okay, so hold on a sec. Now, yeah, I've already missed a lot of stuff here. Debbie says, I'm pretty sure I have nerve crosstalk. Can you be my new primary care provider? I'll give you the right questions to take your primary care provider. All right, let me go get a sweater, okay? It's like 45 degrees. I put on a vest. This is one of my dad's. And the last things I saved of my dad. I wear it all the time, and I feel like I'm close to him. Smells like him. Donna says, can it be more specific? Acacia fiber. ACACIA. You can get acacia fiber. A lot of the acacia fiber on the market looks brown. I think that's kind of like more raw acacia. Heather's acacia fiber is processed. It's white. It's soluble fiber. It dissolves in water. That's what we want. We want a fiber that dissolves in water. So you can go to Whole Foods if you have a Whole Foods or a Sprouts and see what kind of fibers they've got. But again, listen, a serving of green peas, split pea soup, anything like that. 1 cup of green peas, 16 grams of fiber, man, that's a bunch. That's more fiber than acacia fiber. Last night for dinner, I had, what did I have? I had a spaghetti squash that I put some chicken on top of with a little tiny bit of sauce. And then I ate like a half a cup of peas and garbanzo beans and carrots and corn. You got to do what you got to do, my friends. You know, when you're a kid, you just don't, you know, it's amazing how resilient children's bodies are. That changes when we get older. It's what it is. Inga says, what's the name of the newsletter? It's the IC Network e-newsletter. Just go on over to icnetwork.org. It's under, let's see. Let me look real quick. It's under news and blogs. If you go to the news and blog link, the second one is e-newsletter. You can sign up there, or if you just wait about 30 seconds in, a pop-up window will pop up and you can just put your email in there. I don't know, like really weird things are happening right now. And so how many of you are having cell phone calls that just drop? Like 1 minute you're talking, the next minute it's just gone. I feel like that's increased massively. And sometimes people call me and I like answer, you know, this Jill, IC Network, and it drops. And then I call them back. And sometimes I think they've answered and they haven't answered. And I go, I can't hear you. I can't hear you. And I just say, just call me back, call me back. But I end up calling people back. So cell phones right now are being really, really weird. And the other thing too is email is being weird. I mean, sometimes there's a lot of email, sometimes there's none. It feels like it's throttled in some way. I don't quite understand why things right now feel so unpredictably unreliable. And just the cell phones alone are crazy. And now, man, what about gasoline? Holy moly. Gasoline here is $6.50. And they just said, they interviewed the president who said he thought prices might go up. Yikes. I mean, just the cost of aviation fuel is like doubled. Aviation fuel has like doubled. So the ripple effect is real. I did in the IC. So times are hard. It's hard. They're hard for me. They're hard for everybody. Totally understand that. So I've been getting a lot of phone calls from patients who like rely on a supplement like Bladder Builder or lactoferrin or whatever, and they just can't afford it anymore. I want you guys to know that I am trying to keep costs as low as I can. We just dropped our shipping prices even more, which at a loss to us, like a $5 loss to us so far. But here's how you can save money. If you're used to taking 4 of a supplement a day, drop down to 2. And you can make a bottle last 2 months. If you take 2, try doing 1. You can make a bottle last longer. That's an easy way to try to stretch your dollar right now. The second thing is if you sign up for recurring, we can send you a bottle every 2 months and you'll get 10% off. So recurring is cheaper than just buying bottles when you need them. And just plant that seed. And if we really want to keep the shipping down, just like get 2 bottles every 2 months or 3 every 3 months, and that could save you almost $100 a year. So I totally understand. And just, I want you to know, I'm trying really, really hard, but I'm being pushed too. Like the price of our cushions just went up $50. I have no control over that. That's a combination of tariffs and everything else that's happening with the economy. So just know I'm doing my best. And Anna says, exactly, when I see my grandchildren, I have to remind them to go to the bathroom. Yeah. Cece says, yes, drop calls are happening with us. So helpful to talk. Thanks for the chat, Cece. Anytime. Hey, listen, if you're in a flare and you just don't know what to do, feel free to call. It's free. You can call. We have an 800 number. It's free. And if I'm available, I am more than happy to help you. And if you get my I can't talk right now or can I call you later, that just means that I'm working with somebody else. And I'm just telling you right now, I am on the phone every day for hours with patients now. Like I have to, after dinner, I have to come back to write stuff. I mean, there are so many of you who are really struggling right now. One of the pieces of advice that I'm giving to patients is, and you know, we're talking about it in our international leadership groups too, is that it's getting harder to find doctors who want to treat you. It's just that simple. It's getting harder to find doctors who want to treat you, because a diagnosis of IC is like a scarlet letter. And, you know, God forbid you had a great doctor, they retired, and there's nobody to fill that space. And you call that clinic to get an appointment and they say, we're sorry, we don't treat IC anymore. Yikes, what do we do? Well, you got to buckle down and start calling people. But what I say is just take IC off the table. Don't even mention IC. You are a pelvic pain patient. You are a pelvic pain patient. So you're going to call in a clinic and say, I am a pelvic pain patient. And we are trying to figure out why I'm struggling with pelvic pain and discomfort. And I am here because I want you to study my body to help unravel the mystery of why I'm feeling this pain. And then you can say, okay, so I've got pain on the left side. I got pain on the right side. I got pain on the outside. I got pain on the inside. I got pain in my bladder. I got pain in my urethra. I got pain in my rectum. I just have freaking pain. And I am looking for an expert who can help me understand my anatomy, to help us understand why this is happening in the first place. I had a phone call from a patient who was panicking because they would not give her pain meds. They just said, we're done. We're not giving you any more pain meds. And she was kind of, and I say this with love, but I also say this because I've been there myself. She was kind of, God, what's the right word? Like borderline hysterical. But gosh, what's a good way to describe? This is hard to describe. Needy, dependent, desperate, emotional, crying, all the things that anybody in legit pain is going to be. I have been there. I can tell you, July 4th, 1993, I was in so much pain. I was desperate and I would have done anything to get rid of the pain. I was having very, very dark thoughts. That was the worst day of my life. But if you call the doctor and you say, I need pain meds, they are going to immediately label you as a drug seeker. You cannot do that. You have to call the doctor and say, and like they had referred her to a pain clinic, but she didn't want to go. And I'm like, wait a second. Go. Because we need a new set of eyes looking at your body to try to understand where this pain is coming from. This pain is coming from something. We got to figure that out. It's okay to go to a pain clinic if you walk in and say, I don't just want to treat the pain. I want to figure out what's causing the pain and fix it. I want to fix it. I'm sick of this. I don't want to live with pain anymore. And she was not there. She was lost in the hysteria of being in pain for a long period of time that she couldn't rationally even think what's causing my pain in the first place. And again, I've been there. And so the harsh reality is, unlike when I was diagnosed in the 90s, we were given pain meds. Praise God, because they saved my life for sure. Today, you can't walk in and get an opiate. It's much, much harder to get opiates, even though the IC guidelines from the American Urology Association say that they are appropriate. But we do a multimodal approach to pain care now. What does that mean? We do multiple methods. We're not just going to depend on pain meds, because pain meds will never fix the underlying problem. Pain meds will just cover it up. We got to find the underlying problem. We got to fix that underlying problem, whether it's tight pelvic floor muscles, whether it's a fibroid tumor pushing on your bladder, whether it's pelvic congestion syndrome. And for some patients, I started asking her a lot of questions because, my brain, I'm like kind of trying to visualize her body. And it's like, okay, is the pain inside of your body or on the outside of your body? And she was like, oh, good question. Inside. I'm like, okay, is it in your rectum? Is it in your vagina? Is it in your urethra, or is it in your bladder? Where is it? And again, it's like, oh, I don't know. I'm not really sure where it is. Like, okay, this is important. When is the pain the worst? Before you pee or after you're done peeing? Does pain change based upon how full your bladder is? She said, no, it's always there. It's always intense. And it's like, that's a big clue. So you're saying that when your bladder is really full, you don't feel better after you pee? And she goes, no, never. And I'm like, okay. So what that tells me is that it's probably not coming from your bladder. Because if it were your bladder wall, you would have intense pain when your bladder is very full, and you would immediately feel better once you pee. And then I was like, okay, has anybody ever looked in your bladder? She said, yes. I said, what did they see? She said, nothing. She said, nothing. And I went, okay. So what that means then is that you have a healthy bladder wall, and it's something else that's causing these symptoms, like tight pelvic floor muscle, like a fibroid tumor, like pelvic congestion syndrome, maybe a back injury, maybe a rectocele, maybe a cystocele. There's other things, well, a rectocele primarily. And she's like, yeah, but I'm peeing all the time. It's my bladder. It's my bladder. I'm like, yeah, they looked at your bladder, honey. Your bladder was perfectly healthy. My bladder has always been perfectly healthy, despite the fact that I was peeing every 15 minutes and bawling my eyes out. And of course, when you're the patient and they tell you, we don't see anything wrong with your bladder, you're going, how is that even possible? It is agony. And now we look at this a really different way. It's like, okay, this is good news. You have a healthy bladder. I have a healthy bladder. Does it make any sense to do bladder therapies? No. Now we have to do is look beyond the bladder at the other things that can influence the bladder. And that's where it's challenging, because the pelvis is a very small, confined area with a lot of big things happening there. And nothing operates in isolation in the pelvis. Everything influences everything. So you've got your bladder, you've got, if you're a woman, you got your reproductive organs, men or women, you've got your bowel, you got a big chunk of muscle, your pelvic floor muscles, you got ginormous blood vessels, and of course you have big, big nerves. And they're all right next to each other. They're right next to each other. And if something is wrong here and it's rubbing against this, guess what? You might feel it here when it's actually coming from here. And so she just wanted pain meds. And I'm like, I get it. I totally understand that. But if you want to be credible with your doctors, you cannot just ask for pain meds. You got to ask, what's causing this pain in the first place? Help me understand where this pain is coming from. Because in the end, listen, pain is coming from muscles, pain is coming from nerves, pain is from skin and organs. So it's that simple. We got to figure out, are the muscles healthy? Are the nerves healthy? Are the blood vessels healthy? And are the organs healthy? And any one of those can trigger some of this. So Jody said, they won't give me anything for pain still. And I was diagnosed in 2005. I would be very honest and say that anytime pain meds are offered to me, I always accept them. But I sometimes save them for moments like that. And that's probably bad for me to say, but I still have some of the pain meds that were given for me for my mastectomy. I'm not throwing those out because you just never know. But I also don't use them recklessly. I use them very, very rarely. Cece says, can you pick Bladder Builder up for me? Girl, if you're near me, sure. We can meet. I got bottles right there. I'd be happy to meet you and give you one. I feel like I want to start our local support group up again. I feel like we've all been stuck in our homes for a long time because of COVID and then all sorts of other things. And I'm missing being with people more. And so, Cece, hold tight, because I actually might start up our local support group and just invite you to come over to my house. I mean, I had 300 people in my group. I can't invite 300 people to my house, but I'm thinking about it. Jody said, they won't give me anything for pain. Okay, hold on. Robbie said, the doctors are afraid to prescribe pain meds now. We ended up getting some medical marijuana cards for anxiety just to use it for pain without our doctor's knowledge. Hey, you got to do what you got to do. I mean, as long as it's legal in your state. But see, that's where, number one, this was so exciting because in 2019, the PEA study came out that showed that 87% of IC patients who used it reported a significant progressive reduction in their pain. So this is our first option now for people who are struggling with nerve sensitivity and pain. And there are dozens and dozens of research studies showing this works for all sorts of different types of pain: surgical pain, acute pain, chronic pain, shingles, burning mouth syndrome, fibromyalgia, pelvic pain, chronic prostatitis, interstitial cystitis. There is a blog on the front page of the IC Network where I have links to all the research studies. That it is so well researched. It has an excellent safety profile. And so this is what I take to keep my nerves calm, and so and when this was presented at the American Urology Association annual meeting in Chicago in 2019, I will tell you the doctors were thrilled that they could recommend something for pain that was not an opiate. There's no risk of addiction with this. The side effects are slim to none for the great majority of patients. And again, it is so well researched. I mean, I first heard about palmitoyl ethynylamide 25 years ago. We had a doctor in California who was importing it from Europe for his IC patients. He introduced me to the pharmacist who was importing it for him. It was at an American Urology Association meeting in San Diego. And unfortunately, back then, it was just really expensive. But I heard good things about it 20 years ago. But we just, who can afford $1,000 a month? It wasn't going to happen. So it fell off my radar for a long time. What I didn't know is that the price had gone down dramatically as more and more companies started to invest in it. And so when that 2019 study came out, I went to the president of Natural Approach Nutrition, and I brought him that study, and I said, can you please make this for an American market? And he did his research, and he found it. And it is very affordable. This is like under $50. And you can take one a day, you can take two a day. I just take one a day, and it's been stunningly helpful for me personally because my skin, I have small fiber polyneuropathy. So that hit really with menopause, redhead, hello, sensitive skin. Menopause just made it exponentially worse. And I felt like I was being poked by pins all night long. And I had some nights when I just couldn't sleep at all. It was very frustrating. And then this came out, the PEA research came out, and I thought, what the hell? I hate taking stuff. Got to understand, I hate taking stuff because I'm so freaking sensitive anyway. I feel like I'm the side effect queen. So I'm very, very cautious with medication, anything like that. But I just couldn't sleep. And so I just all right, I dove into the research. Research looked great. I thought, I'll give it a try. My skin is perfectly normal now. My small fiber polyneuropathy is gone. And what's really cool about PEA is that the results are durable. What that means is that they last long after you stop it. So I will take it for a month or two, and then I run out. Like I literally just picked up a bottle this morning from my warehouse. I haven't taken it for 6 weeks. And as soon as I feel my skin getting a little prickly, that's when I take it again. So PEA is a viable option. But then, Robbie, getting back to your point, medical marijuana is certainly a viable option. CBD from hemp is certainly an option. And again, if we know the source of the pain, we can treat the source of the pain. So if you're having a pelvic floor flare, the most important thing you could do is get your wand out and just massage the muscle and get it to release. If we can get that muscle to release, that's great. Or if you've got a trigger point, we want to massage that trigger point. Or if you've got pudendal neuropathy or pudendal neuralgia, maybe a nerve block would help. Maybe Botox would help. Be the squeaky wheel. Don't sit at home and suffer in silence at home. You get back to your doctor's office and say, I need to understand what specifically is wrong. What is hurting me? Don't just say, I see. I want to know, is it my muscles? Is it my bladder wall? What is it? Help me understand. And if you looked at my bladder wall and my bladder wall was normal, then what else is it going to be? Let's look for other things. I chaired the State of California Pain Conference about 15 years ago. And I testified up in Sacramento. I had an opportunity to testify on the needs of IC patients and the needs of pain patients, and help our governor at the time sign our Pain Patients Bill of Rights. The biggest problem that we have, because I've worked with the Bureau of Narcotics Enforcement, I've worked with the DEA, we did that. I brought them all in for this pain conference. And the irony is that the head of the Bureau of Narcotics Enforcement in California at that time actually was a pelvic prostate pain patient. He totally got it. He's like, yeah, legit patients need pain care. The challenge, there are two challenges. Number one, and do not even get me started on the opiate guidelines. The new opiate guidelines that were created at the federal level were not done with any chronic pain experts. And they immediately cut patients off, including patients who were using meds stably and successfully at low doses. They were all cut off. And when the guidelines came out and the pain experts read the guidelines, they were like, who the hell wrote these? Because they did not demonstrate any knowledge of appropriate and effective opiate use. And it turned out when they released this committee, and I think it was an FDA committee, when they actually released the identities, they were the people who benefited from cutting off the opiates. They were people who ran drug treatment programs. And so the damage was done. These guidelines came out. They were very harsh. They were very overly interpreted. Even though they've been revised, the fear is still there. And the other challenge is that there is an industry of illegal providers, people who import stuff from China that's very, very dangerous. So, there's good and bad associated with it. It's like they've forgotten that there are lives. There are people suffering that need help. They just cut you off. I told them, when I had my gallbladder removal, when I had my mastectomy, and even when I had my hysterectomy, because I've now had 3 big surgeries, I told every surgeon, I'm not doing this without opiates, period. That means I'm going to die of cancer. I'm going to die of cancer. I refuse to have this surgery without opiates. And her answer was, I would never do this surgery without opiates. You are fine. You are right. But I kind of go a step farther and say, then I want the prescription in my record now so that I can fill it so it is at home when I get home from the hospital. And they're like, not a problem. You can have it. I don't trust them at the hospital. I've heard too many stories of patients being sent home with Advil and with Tylenol. And so I have a very clear discussion at my pre-op appointment. And I just say, listen, I want the prescription now. I'm not asking for 100 pills. You just give me a week's worth, whatever it is. I'm going to fill it now. I'm going to have it at home. So when I get home, I'm good. Got to be proactive these days. Robbie says, when I have bladder spasms, they spread to my rectum. I'm unable to pee, but can painfully poop. That's, Robbie, you're describing a pelvic floor flare. You might notice too that when you have diarrhea and you're dealing with a big attack of Montezuma's revenge, you can't pee because all those muscles have locked up tight. So that's probably a pelvic floor spasm as compared to a bladder wall spasm. Cece says, I agree. I always take what's offered and hang on to them. Yeah. Cece says, my adult daughter and I would love to come and chat. Okay. Rebecca says, I started low-dose naltrexone 3 days ago, 1.5. It's helping with pain and inflammation. I have a new doctor who won't stop till I get some pain relief, Hunner's lesions, and estrogen atrophy. Good. Kathy says, I started taking P-leaf. It's making a difference for me. I'm praying it continues. Yeah, the research is good. Inga says, what's the name again? I'm not sure the name of what. Oh, P-leaf. There you go. Brandon said, ever since Dr. Evans retired, I feel like the staff there have nothing to offer me. Yeah. This is, you're not the only one who said that to me specifically. I think it's incumbent upon every specialist to have a backup plan for their patients. And listen, Rob Evans, you couldn't find a nicer, more prepared, more professional doctor than Robert Evans. He is always voted number one in our Doctor of the Year campaign. Lovely, kind, generous man. Who just seemed to go on forever until one day he couldn't. Dr. Evans, he said I could share with people what happened to him. He suddenly developed a blood clotting disorder. This almost a year. It was a year ago last January. And his legs and arms filled with blood clots. I last talked to him last fall, probably 6 months ago. He wanted me to tell you that he's doing everything he could to come back. The biggest concern with the way this presented is that it's often a precursor for pancreatic cancer, to have these random blood clots happen. But every time they've tested him for cancer, nothing was found. So they don't think it's pancreatic cancer. So then the next theory is that it was a rheumatologic condition. And the final theory is that it's related to COVID, because COVID attacks blood vessels. Either COVID, he had COVID shortly before it began, if I remember correctly, but maybe there was also concern about the vaccine. And so he was unable to walk without pain, certainly was unable to stand at an OR. Brilliant surgeon. So he went out for an extended leave. His return date he hoped would be July 1st, but that obviously passed. And I do think he is now formally retired. But, in that case, I think everybody thought he would go on forever. So I don't know if there were, it was just too unexpected. It was just so incredibly unexpected. And again, it's just nothing about him. He's a wonderful, kind, decent professional who specialized in IC. Now it's up for the medical center to step in, and the urology department and the urology chair to step in. I did hear from somebody, but this is secondhand, that they thought they had somebody who was going to come in to take his patient, but that was probably a couple of weeks ago. I don't know that for sure. Stretch, my friend, stretch. I did get bad news from the doctor, and that is my scoliosis has gotten worse. You would never know I have scoliosis because my hips are level and my shoulders are level, but I actually have an S curve. I'm supposed to be an inch and a half taller. It's all compressed right there. Scoliosis often happens during growth spurts. I had a 6-inch growth spurt in 6th grade, and I was on my way to a 6-inch growth spurt in 7th grade when it happened. I think my spine just couldn't support my weight because I was a chubby kid with big boobs back then. Listen, the women in my family have watermelons hanging from their chests. It starts young. That's one of the reasons why I opted for a mastectomy. It's so nice not to have that anymore. But unfortunately, as you get older, your muscles get weaker and your spine starts to do this. And so I'm starting aggressive physical therapy this week. And hopefully I won't have to have fusion surgery. It's 45 degrees. Which is not good. I got two 45-degree curves in there. So it goes this way and then it goes this way. It's an S curve. I am annoyed with my body. Kathy says, can parasites like a tapeworm exacerbate? Yes, there are parasites that can infect the bladder. Tapeworms tend to stay in the bowel, though. It's going to be other types of parasites that are going to affect the bladder, because with a tapeworm, you generally swallow the eggs, and then the eggs go, and then the little worms hatch, and then they attach to the colon, and they end up feeding off of us. And so I did have a tapeworm. I did. You know where I got it? I got it in Hawaii. It was disgusting. My cousins had me swim in, it was on Kauai. I had cousins who lived there, and they were playing a joke on my sister and I, and they had us jump into a brown muddy river. And I accidentally swallowed river water, and I got myself a tapeworm. And I was 18 years old, and there was nothing more embarrassing than an 18-year-old to have to leave a stool sample. It was disgusting, and I was so horrified by it. So tapeworms happen. Robbie said, if I do the routine with the lactoferrin for my Hunner's lesions and it doesn't work, do I look into posterior fornix syndrome? I would do both. I mean, listen, posterior fornix syndrome, just call making an appointment with your gynecologist. I mean, it's like a 30-second test. They just basically what they do. So what is posterior fornix syndrome? Posterior fornix syndrome happens when a ligament that holds your vagina in place gets broken, and guys have the uterosacral ligament too. Well, they have a similar ligament too. And so when this ligament is broken or stretched out, this directly affects and inflames the nerves of the bladder, because the nerves come out of the bladder and rest on top of the ligament. So the ligament is kind of like a placeholder for nerves. So when this ligament drops, the nerves drop and the nerves stretch. And yikes, that's a bad thing, because then the nerves get super inflamed. The nerves start sending they send messages to the spine, help me, help me, help me. It is not actually the bladder itself that's a problem. It's the nerve outside of the bladder that's a problem. The brain doesn't know that. The brain thinks, okay, this patient has frequency urgency pressure pain. It's got to be a bladder problem. And you get this really weird compensation for that. And it's a signaling problem. And so essentially, it's always important to rule out posterior fornix syndrome. Okay, so what is a fornix? That's the next question. Let me see if I can think of a good example. Okay. Where the vagina hits the cervix, which is the entrance to the uterus. Okay. It's not flat. It's not like here. Okay. Vagina, uterus. Okay. It's not like they just meet in the middle and it's a continuous tube. It's not flat. Actually, it's like the cervix looks like pursed lips, right? It's like this. And so there are pockets around the cervix and kind of, it would be better if I could draw it. Let me see if I can draw it. I'm not speaking it well. Okay, hold on. Give me a piece of paper. Let me see if I can draw this to make a little bit more sense, because it's hard to describe. Okay, so Okay, so nope, that's wrong. Oh my goodness. How am I going to just... It's a weird intersection. Let me just say this. It's a pocket. There are just nooks and crannies around the cervix. And so what they do is they put a little speculum into one of the nooks and crannies and just gently lift. And if they can lift it and it makes your pain go away, that means you have a broken ligament. So just call and make the appointment. I mean, that's just a really quick office visit. But bring the papers, print out the article from our website, or bring the research study so that they can read it. There's a case study of a patient being healed of Hunner's lesions when her posterior fornix syndrome was fixed, when that ligament was repaired. So, Judy, hold that question. Robbie said, could posterior fornix get injured during hysterectomy? Absolutely. Symptoms started 6 months after hysterectomy. Anytime symptoms start after a major surgery, we really ponder and consider the concept of surgical injury. Hysterectomy is particularly known for being very rough on the pelvis in general. It's very common for patients who have gone through hysterectomy to have pelvic floor spasms, pelvic floor injury, bladder injury, nerve injury. And could there be a ligament issue? There certainly could be. It's a good question to ask. Judy says, how does physical therapy help scoliosis? So when you have a curve in your back, so let's just do a single curve, you've got muscles on this side and muscles on this side. Normally, if your back were straight, the muscles would be straight, right? But if you've got a curve, you've got one side is stretched out and weaker. The other side is compressed and often very tight. And so with physical therapy, what we do is we want to strengthen the weak ones to see if we can kind of get those muscles to support the spine a little bit better. And we want to release the tight ones. So, muscle health is everything. It's just everything. I've always said, if there's one thing I could fix about my body, it's the damn scoliosis. It just pisses me off that it happened in the first place. I've lived with it for many, many years. They almost did a spinal fusion when I was young. But the doctors told my mother that there was a 50% chance I'd be paralyzed. And she said, hell no, I'm not doing that. And what I learned, because my scoliosis was very painful back then. It was very hard to sit. It was very hard to sit at school. It was almost impossible to sit at a sewing machine. I loved to sew. The worst part was lying down and going to sleep. I would lay down in bed, and there was like this 30-second period where my spine would just settle and I would just get this agonizing pain. And what I learned is that the more I laid down, the worse I felt. The more I sat, the worse I felt. I learned as a child to be active. And even though my doctor said you need to lay down, I went, no, I feel worse when I lay down. And that's when I became an athlete. And I even played tennis, and I played with two hands to balance my spine. And the best thing you can possibly do for scoliosis is swim. I love swimming, but our pool burned down. So it is what it is. COVID didn't help, and menopause certainly hasn't helped. So I have a lot more pain sitting and working. That's for sure. Sherry said, I have scoliosis, less than 45 degrees. They said it was mild, diagnosed in 7th grade. You're now 50. Could it be affecting my pelvic floor? It certainly could be, because what happens is you get one hip that slightly rotates one direction, the other slightly rotates the other one. Like I have chronic tension on the right side of my neck, chronic tension. I did physical therapy for a year, and the physical therapist finally said, Jill, this has to be from your scoliosis. There's nothing else that we can do. And so from above the waist, I'm tight on the right side. Below the waist, I'm tight on the left side. And I was considered once I became an athlete and lost a bunch of weight, I was mild, but now I'm moderate and right at the borderline of severe right now. And I am freaking annoyed with my body. The 50s were great. The 60s stuck. It's like there's always something going on. Brandon said, my urologist referred me to a gynecologist that does advanced pelvic floor injections. I just find it surprising that a gynecologist will even know how to inject a man's pelvic floor. Maybe she would be good. I would give her a chance and see. You know, Brandon, here's the thing. It's a lot of gynecologists who specialize in pelvic pain for men. They do. And, you know, guys face special obstacles because when a guy has frequency urgency, it is almost immediately assumed that they have a prostate problem. You know what I mean. You're given antibiotics, then you're given prostate meds, and getting that urologist to look beyond that, to look at the bladder, or even more importantly now, really to look at the muscles is very, very difficult. Listen, I sat on the AUA guidelines for male pelvic pain for 2 years. And the, and granted, I'd just been diagnosed with cancer and I couldn't do a lot of things that I wanted to do, but I still sat in on the meetings. And one of the points that I made to them is in the guidelines, we have to get the doctor to ask the guy, were you playing sports when you were younger? Was there any injury when you were younger? Just instead of just assuming this patient has an infection, let's not jump on that bandwagon. We got to start looking at muscles. Because here's the deal. Research has shown that 87% of IC patients have tight pelvic floor muscles. And for guys, it's higher. And I believe it's 95% of guys. At least in my office, I will tell you virtually every guy that I work with, when you spend enough time probing and asking the right questions, we find a pelvic injury. So getting a urologist to specialize in muscle, it's almost impossible, except for like Dr. Jerome Weiss when he was still alive. So gynecologists are great. Go for it. Do it. We have a lot of physical therapists now trained with men also. So I say go for it. You got nothing to lose. Just go for it. Hey, listen, if I were in 7th grade and I went and sat in a urologist's office with a bunch of guys over the age of 70 with prostate problems sitting there going, why am I here? And I know you're going to do the same thing in a gynecologist's office. It's like, I'm a guy. Why am I here? But you know what? Just do it. No shame. Kathy said, I have the IC Diet app. I think I heard you were going to update it. Is that true? If so, when? Yes, I'm now working with a new app developer in South America who's doing it for us. And it looks great. And so I hope to have a new app in the next month or so for the IC Diet. The diet app you have right now is gone. It will never be updated. So hold on to it while it's working, because we will never have that specific app again. It is over. That sucker cost me $40,000 in the end. And it never paid for itself. Apps are way too expensive to maintain. $20,000 an update. Now costs are a lot better, and I'm not paying that much. And I was like, okay, if it's under a couple $1,000s, I maybe will do it. Robbie said, would an inversion table help scoliosis? I don't know. I mean, that's a good question. I mean, I know that I feel better doing this, right? anything that stretches my back like that, and doing the backstroke. Sometimes I will lay on my couch, on my floor, and I will do the backstroke and just kind of stretch it all out like that. It's amazing how many I see patients have scoliosis. A lot of us do. And I think that supports the whole pelvic floor thing, that scoliosis is going to affect the pelvic floor. I just wish it didn't happen. I mean, we just really don't I mean, sometimes it's genetic, but there's not anybody in my family who has scoliosis. I'm just the lucky one. Damn it. I told my best friend, I said, okay, if I have to have surgery, I'm moving in for 6 months at your house. And she's like, or I'll move in with you, either or, you'll be okay. And it's like, okay, because scoliosis surgery is really risky surgery. I don't want to have scoliosis surgery. But I do sit here and I do this now. I'm doing a lot of this as I'm working. Michelle says, what do you suggest for vulvodynia? Okay, so vulvodynia means that you got pain on the vulva, right? Vulvodynia. Dynia means pain, vulva means vulva. So we got to figure out what is driving your vulvodynia pain. So a couple of things that we're going to look at first is going to be the quality and health of your skin. If you are older, if you're dry, if you're in estrogen atrophy, if you're on birth control, if you're on Lupron for endo, if you're on estrogen suppression meds for cancer, that's going to directly affect the vulva. And the vulva, dry mouth hurts. When you have a dry mouth, it's very uncomfortable. Well, a dry vulva is very, very uncomfortable. And so the first thing we would do is, again, if it's dry and it's an estrogen atrophy issue, we're going to use estrogen and estrogen cream. When you give that skin estrogen, it immediately plumps up and starts to make mucus. So that's the most natural thing you can do, is help your body make its own natural mucus. The second thing we can do is something like this, Vulva Balm. Vulva Balm is fantastic. This is my personal bottle. I use it myself. I always use it for demos. So it is made with an organic olive oil, sea buckthorn oil, and avocado oil. It's a very, very light. You can see it right here. Super, super light. And it mimics normal mucus. So you can put this on your vulva as a barrier, and you can use it every day. You can use it a couple times a day. You use it like this is too much. What I just did is actually too much. Okay. The second thing we're going to look at is your vulva being irritated by anything? So the vulva, especially as we're getting older, becomes much more chemically sensitive. So fabric softener, laundry detergent, menstrual pads, mini pads, douches, bubble baths, bath salts. Those are all things that have the potential of irritating the vulva. So let's make sure there's no chemical irritation going on. We're also going to look at the quality not the quality and health of your skin. We already did that. Your muscles. So as an example, I broke my tailbone at the age of 13. My very first symptom, aside from me feeling that broken tailbone, not being able to sit for a couple of days, was that I couldn't sit through class. I had to pee all the time. Okay. And then the second symptom that I had that started in like 9th grade is that I felt like I had a yeast infection all the time. I had vulvodynia, like severe vulvodynia, and it was primarily on my perineum. And hold on, let me get my... Hold on a sec. Here it is. Okay. Okay, again, guys, this is my dad's work vest. It's stained. Don't worry about it. If you see a spot on it, it's fine. It's a connection I have with him. He died 2 years ago. So, okay. So let's think about it for a moment. Let's talk pelvic floor real quick. So here is your pelvic cavity. This is the front. So you can see here's your pubic bone, which is actually two bones that are held together. Hip bone, your spine. And if we turn it around, we've got our sacrum. We've got our tailbone right here. And we've got all the muscles that attach to the tailbone, right? So the tailbone doesn't just free swing. The tailbone is the foundational center of the pelvic floor. And you can see that your muscles are essentially a mirror of each other. You've got muscles that go this way and you've got muscles that go this way. Okay. And then from underneath, we've got muscles right here so that when you sit on a bike seat, you're sitting directly on muscles. Okay. But those are the mid-level muscles. The most shallow muscles look like this. These are what we call the levator ani muscles. And so what makes the pelvic floor muscles so interesting is that they're skeletal muscles. These are muscles that help us move our body, open and close our legs and walk. But they're the only skeletal muscles in the human body that control major bodily functions because, hello, there's three holes. There's a hole for the rectum, there's a hole for the vagina, and there's a hole for the urethra. But you will notice the muscles wrap around the rectum. They wrap around the vagina. They wrap around the urethra. So when these muscles get tight, what do? They squeeze things. They start squeezing things. That's why constipation is a well-known symptom of pelvic floor dysfunction because the muscles are just locked down really hard. That's why pain with intimacy, pain with sex. And there are some women who suffered injuries when they were very young, and you can't even get a finger in there. Their muscles are locked down so hard, they've never had a pelvic exam. I've worked with them. And of course, they wrap around the urethra. And so it might take 5, 10, 15, 20 seconds for you to relax enough to release urine. Okay. So we got a lot of muscle stuff going on. So if, for example, the muscles are squeezing nerves that affect the vulva, that could cause vulvodynia. If the muscles are restricting blood supply to the vulva, that can cause vulvodynia. But here's what's interesting. So this piece of tissue between the vagina and the rectum in a woman, this is called the perineum. Okay. So when my vulvodynia was really bad, man, this was my hot spot right here. It felt like somebody had scrubbed it with metal, or sandpaper. As I was on fire right here. And I'd, get myself down to the gynecologist, please help me, it's so bad. And they look at my skin and they go, Jill, it's fine. We don't see anything. And you're like, I can't sit. It's so bad. Please help me. And they're like, we don't know what to do. We don't see anything. And finally, the doctor said, you have the most sensitive skin I have ever seen in my life. So the question then is, why are the nerves so sensitive right there? Why is everything so sensitive right there? The answer came in this book, my favorite book, Breaking Through Chronic Pelvic Pain by Dr. Jerome Weiss. It turns out that immediately under the skin of your perineum, you can see it right here. It's a whole bunch of muscle. Like there's a ton of muscle right there. Those muscles are connected. I don't know if I can zoom in right here. Okay. Rectum, vagina. You see that little knob right there? See what that says right there? That's the perineal body. That's a freaking attachment point for 4 muscles. And if any of those muscles are tight, guess what? Perineal pain. It's perineal pain. It's muscle pain. And I think of all the yeast medicine that I took back then. Oh my God. And guys have the same thing, you know? Guys have the same thing. It's just right there. So I would want to know what's going on with your pelvic floor. Okay, so skin health, chemical injury, pelvic floor health. And if you're having pins and needles, areas of numbness, that really is pointing to nerves that are compromised in some way. So if you ever feel like pinpricks, like a needle's poking you on the vulva, that's usually from a muscle squeezing the pudendal nerve. Tanya says, just caught you talking about scoliosis. I have upper scoliosis, kyphosis due to a compression fracture of T9. What a mess. I had custom orthotics made for my shoes to help you keep your hips in alignment. Excellent. Excellent. That's perfect. Michelle said, yes, it feels like sandpaper. I mean, that's like the perfect descriptor, isn't it? It's like literally it feels like somebody is rubbing your skin or has rubbed your skin with sandpaper. And I had that all through high school. And I would come home and like I just half of the time I just got into a hot tub. I mean bathtub. We don't have a hot tub. I would just go sit in the bathtub for an hour. And there were moments I can remember when I was in college. Oh my God, trying to wear jeans. Yikes, with that big thick seam going across there. That was impossible. And even now I still wear pretty much stretchy yoga pants, right? I mean, I love stretchy pants like this. Jeans look cute when you're young, but when you're older, you just don't care anymore. Gina said, I had a tailbone injury as a child. I had UTIs all throughout my youth, always put on antibiotics. I started Urgesic Blue this week. After 3 days on it, it's been a miracle. I was able to last through 12-hour shifts. Yay. Yeah. So Gina, so you're like my twin. And I think that there's a lot of legacy nerve damage and nerve sensitivity from breaking your tailbone. I do. And I think that can last for decades. Like I said earlier, I mean, and I don't know about you, but man, the nerves in my rectum are so sensitive. I feel anything in there. And usually it's just right before I go to bed. During the day, I'm fine. But as soon as I'm trying to get ready to go to bed, if there's anything in there, it annoys the hell out of me and I got to deal with it to sleep. So just what it is. But I'm really glad that that's helping a little bit. But I would encourage you to go have a pelvic floor assessment. And let's just understand what role, if any, your muscles might be playing in some of this long-term pain. I mean, because like you said, listen, I was put on antibiotics for years too. But I still had symptoms. And there are a lot of patients right now who are still on Elmeron, even though it's now well known to be linked to blindness and bowel issues. And I ask them, why are you still on it? And they go, well, it's the only thing that helps. And my answer is, but wait a second. If it fixed you, you wouldn't need it. So the fact that you have to keep taking it means that it's not fixing you. It's just covering up symptoms. Because, hello, this is an Elmeron postcard. It acts to cover up the bladder. But it's a Band-Aid. It doesn't repair anything. So we want to know what the underlying problem is. Because if we can fix the underlying problem, then you wouldn't need that in the first place. So I call that chasing the symptoms. We don't want to chase the symptoms for decades. That'll never get you what you need. We want to find the underlying problem and fix the underlying problem. And that's exactly why we phenotype. Phenotyping is everything now. Everything. I was right. I was right, my friends. I was right. Sherry says, you have a loose SI joint? Me too. Left side. We need that on a t-shirt. Wait, we need what? I'm freaking annoyed with my body. Yeah. My favorite IC t-shirt idea is still, we do it frequently in urgency, urgently. You remember like 20 years ago, we had all these "we do it" t-shirts that were all kind of vaguely implied a sexual kind of connotation, but not really. You know, the people in the know would know what that means. I still think the perfect IC t-shirt is "we do it frequently and urgently." I have a, you got to laugh, my friends. You have to laugh. You got to find reasons to laugh. You just have to. Okay, so what's coming up? So I've got 2 new blogs on the IC Network that I put up this week. One on the post-UTI hypersensitization syndrome, the other one on lupus cystitis. And then we have a couple more articles that Stacey put up. We always put up new content every week. We sent out the big newsletter. Now here's the thing, and I'd really love your feedback on this. For those of you who have followed the IC Network for the last 20 years, my style is to give you a lot of information and content. So when I do a newsletter, I don't send out newsletters every day or every week. I do them like once every 6 weeks, but that sucker's long. There's a lot of articles in there. And that's not the trend anymore. I'm one of the few people who do that. I have had many, many people and professionals say, Jill, your legacy, you're doing old stuff. You should be doing new stuff now. And I'm like, okay, what's the new stuff? And they go, 1 newsletter a week with 1 article. People don't want to read anymore. Just send out 1 topic-centric newsletter a week. And I'm so busy, it's hard for me to even conceive of finding the time to do that. But I may start doing that. I may do and I'm tending to release them on Saturdays. I may do 1 shorter newsletters, like 2 shorter newsletters a week. You tell me, would you prefer a short newsletter, which is 1 article, or would you like the big long newsletters with lots of articles? Again, the sense that I'm getting is that, and listen, our open rate's really good. Our open rate's like 45 to 50%. So, we've got 35,000 who get our newsletter. At least 17,000 are reading them. Sometimes more, sometimes less, but right around there. So I know that people find them valuable, and I know that you trust me because I don't send out spam. I've been really, really careful never to do that. But the trend is the trend. I have to accept that the things I used to do 10, 20 years ago are not necessarily the way we should be doing it now. Sherry says she likes the longer newsletter where it's all in one place. Okay, I appreciate that feedback. Inga says, is P-leaf the same as PEA? Absolutely, it's the same thing. Gina says, how do I get the newsletter? Let me give you a link. Here, hold on a sec. Let me just, I can grab that for you. Let us see here. So you can sign up on that page. And then YouTube, I'll give you the link where you can sign up. The next project is we'll be putting together our spring magazine. It's almost all written. I'm just going to do a couple more articles for that. Our magazine, the IC Optimist, which is here. This is our latest one. This is our winter one. Features articles from our website and also articles that I write just for the magazine. So this is what our members get, because this is how we pay for all this. We need members, like legit. We need members. Listen, I paid for everything the first 5 years of the IC network. I ran out of money. There was no way I could just give it all away for free. We have to have money coming in to pay some of the bills. There's just no doubt about that. Okay. We are in the process of building our new store. Then I will be doing the new patient registry for the Elmeron eye complications. That's going to be a big project this spring. I am asking everybody who has taken Elmeron, who has ever had bowel symptoms from diarrhea to upset stomach, polyps or worse, we have got to start gathering this data, because I want a revision of the black box warning to include the risk of polyposis and bowel issues. And the only way we're going to do that is if we start getting the data. And so we need every single patient to go to the MedWatch database and report their experience. If you had a bad experience, I mean, if you're fine with it, that's fine. But listen, if you had diarrhea, if they did colonoscopies and they found polyps and bowel stuff, you've got to file with the FDA. We have got to get this data. That's the number one way we get the FDA's attention, is with their own data. Second way we're going to do that is with research studies, which we already have. We're going to do a patient registry. And our goal here, again, is to make sure that patients, because there are still doctors that are telling patients and prescribing this medication saying it's safe. We had somebody last week who came in who said, yeah, my doctor just prescribed it for me. He didn't tell me there were any issues with it. Listen, this is the only approved medication for IC, oral medication for IC. The company has since paid $43 million to IC patients and their attorneys because they are going blind. This is not a little thing. Patients are going blind. And now the latest thing that's happened is it's also causing uncontrolled polyp growth. So one of my clients who is blind from it, who did get a settlement, they discovered that she had carpet polyps. See, Julie says, where do we go for Elmeron and having over 150 colon polyps? That's it. That's it. That's what it's doing, carpet polyps. And these patients who get carpet polyps have to have sections of their bowel removed. I believe in informed consent. The reason why I jumped on this in the first place, because I'm the one who told you about this. ICA didn't tell you about this. Nobody else told you about this. I'm the one who found that letter to the editor by the eye researchers from the Emory Eye Institute. Shocking, showing that patients were having retinal problems. We have another new study that shows that retinal problems can develop long after you stop the medication. Long after you stop the medication. That's new research that came out this week also. Informed consent. Informed consent. What does that mean? That means that you know the risks versus benefits before you put that first pill in your mouth. That you have the opportunity to make an educated, informed decision about whether this medication is good for you or not. Whether you know the risk. If you knew that this medication could make you go blind, would you have taken it? Now, listen, patients who are desperate will do desperate things. Some patients would say yes. Other patients would say hell no. If you knew that this medication could lead to you losing your bowel, would you have taken this? So, and of course, now we have research showing that patients who have, one patient who had it as a bladder installation, never took it orally, just had it as a bladder installation, very, very low dose. He's now got it. And there are now 3 patients who had Elmeron or Pentostin injections for arthritis. They now have it. So this is not a little thing. This is a big thing that is changing lives for the worse. And our job is to protect the next generation. We want to make it better for the patients coming after us. And so this spring, we're working on, I already have the patient registry outlined. I already have support from various researchers. I'd like to get a couple more researchers to come on board. And let's see. And the cool thing about a patient registry is you're not identifiable. You're going to get a number. It's going to be the only way that your case is going to be linked to it. It's all about preserving your confidentiality. I've got 2,000 patients in our eye study. I need 5,000 for the bowel issue, because I'll tell you one thing. We knew from day one that some patients developed diarrhea. And back then in 1996, 1997, when it was approved, we were told to tell patients that it came from the capsule, to take it out of the capsule. Now we know that's not true. Now we know that it's the medication. And if I remember correctly, the theory behind the bowel issue, again, if I remember correctly, was that the structure of the molecule was similar to another molecule that was known for damaging tissue. We also have another medication very similar to Pentostin that's also been linked to some issues. Julie, it's not ready yet. But if you can email me, icnetwork@mac.com. I have a special support group for patients who have issues. And so we're now just trying to get together once a month by Zoom. So pop me an email so I can add you to that list. It's icnetwork@mac.com. Anybody who's had any bowel issues at all from Elmeron or any eye or bowel issues, you are welcome to join our special support group. It's just so important that you see that you're not alone. It's important that you see and hear from other patients who have gone through exactly what you are going through. And generally, Julie, just so you know, virtually every patient that I've worked with, it starts with 1 or 2 polyps that they find on colonoscopy. They remove them. They go back and look a year or 2 later. The polyps have regrown and more polyps have grown. And so you've gone from 1 or 2 to maybe a dozen. They remove those. All the biopsies come back negative. But they go back and look a year later and you've gone from a dozen to 50 polyps. Or in your case, 150 polyps. It starts to look like there's a shag carpet of polyps, in certain sections of the bowel. Polyps come in 2 shapes. Some of them come in mushrooms. So they have a bulbous center with a stem. Those are really easy polyps. They just cut it at the stem and then they biopsy it, make sure it's not cancer. Other polyps are very flat. So they don't have a stem. They're very flat. And unfortunately, it's the flat polyps that are kind of considered more dangerous and more at risk of cancer. And so that's kind of what they're seeing. There is an article on the IC Network website, The Tragic and Tarnished History of Elmeron, that goes through the FDA approval and gives you real facts on when the eye issues were found, when the bowel issues are found, and gives you every research study published supporting that. And so as an example, numerous, I'm not going to say numerous, maybe 3 case studies were published of patients who had really severe inflammatory bowel disease who were using Elmeron. And when they stopped the medication, their bowel completely healed. So those are published. And And then there's multiple studies. Again, I have them all on that article, and I would encourage you to look at them, because at this point in time, it's heartbreaking what's happened. It is absolutely heartbreaking what has happened to so many patients. And so, as an example, a 79-year-old woman who is one of my clients, again, she's already blind, already needs home care, did not get a good enough settlement to pay for her home care. She was just told she needs to have her bowel removed. She's got carpet polyps. And she called me hysterical like 2 weeks ago. And she said, Jill, I don't even know if I can survive that surgery. And even if I do, here's the problem. I'm blind. I can't take care of it. I can't change the bag. I can't do anything. What do I do? What do I do? And I didn't have an answer for her. It's heartbreaking. So Julie here just said she lost her entire colon. Exactly. I'm so, this is the single most important work I've done in my career in IC. I will not back down. My attorney said, back off, Jill. You don't know what you're doing. People are going to sue you. The companies are going to sue you. They're going to do whatever they can to shut you up. And I had people say, sit on it. Just sit on it. Wait. I couldn't do that. I couldn't sit on it. I couldn't live with myself if I waited a year before I told you, hey, guess what? We've got eye researchers who are finding the patients using this medication are going blind, because I believe in informed consent. And I disagreed with my attorney, and I was the first person to break the story to the IC patient population. And I knew at that moment that I changed the IC world forever. But I couldn't hide it. And I refused to hide it. And now this is a big deal. And hundreds of patients, thousands of patients have sued. Thousands of patients have been affected. And they have received large settlements. Biggest settlement so far is $1 million for their eyesight. But now we're seeing all the bowel issues. Those lawsuits haven't happened yet because we don't have attorneys. The attorneys are basically saying they want a little bit more information. They want more research. I know that every time I talk about it, I'm walking a very delicate balance. I want to be very careful about what I say. I want to support it with the research. This is not opinion. This is backed by research. This is backed by the Emory Eye Institute. And you can damn well bet that company would not be settling if there wasn't research proving the strong association. So we got to stand up and be counted. And I'm proud that I'm standing up and being counted for you guys. And Julie, for you. For you. Shouldn't have happened. Gina says, 10 years ago, I was going to the Smith Institute in New York. My doctors back then would not prescribe Elmeron because of the side effects. Praise God. That's great to hear. And, because in the end, here's the thing, is that they first requested FDA approval in 1991. It got denied. It was denied for 5 years. And the reason why it was denied is because the research they considered inadequate. That basically the research the company submitted to the FDA for approval showed that only one doctor had success with it. All the other doctors didn't have success with it. And that's what the FDA said. The FDA said, listen, you basically what you're saying is that there's only one doctor who's used this safely and effectively. All the other doctors have not. So the FDA said, please give us a study without that doctor, because that doctor happened to be have a financial investment in it. So the FDA was very clear, and they had meetings and they talked about how they wanted that research study to look. And they did not want that doctor included. They wanted a new set of urologists so that they could neutrally determine if this product was successful. So they denied it. And the company said, we don't want to do another study. So they just reformulated the data, reanalyzed it, denied again. And then the company again still didn't want to spend the money to do the study. What they did is they included some compassionate use data because it was given compassionately. See, the way it works, the way it worked with this is when the drug was first formulated, they went for what we call orphan drug approval. That doesn't mean it's safe. It just means that we have a rare disease for which there are no treatments or very, very few treatments. Oh, no, hold on a sec. I got it backward. Orphan drug approval means that they get a tax benefit because they're creating something for a rare disease. Doesn't mean that it's safe. It's really a financial benefit. Then the next step is compassionate use. If you're approved for compassionate use, that means you can give it to patients with rare diseases for which there are no treatments. So it got compassionate use approval. Doesn't mean that it's safe, doesn't mean that it's effective. It just means, hey, we've got a population of patients with a lot of options. This is available. And so if you look at the early patient education materials, they talked about that. Back with the ICA, they advertised, you can get this on a compassionate use basis. I've seen those ads. And then 5, 6, 7 years later, in 1991, they went for FDA approval. And then they had a lot of data, patients who had used it on compassionate use. So they then sent that to the FDA and miraculously it got approved without the research that the FDA asked. So it got approved in 96. We don't know who, we don't know why, we don't know where. There was a very good investigative report. And the big question was, why did the FDA change their opinion? For 5 years, they said, give us more research, and then suddenly they just approved it. So there it is out in the wild. 18 years is out in the wild, prescribed to virtually every IC patient. Finally, 2014, 2015, that research study was completed. It was led by Curtis Nickel up in Canada at Queen's University, one of the best IC researchers in the world. It was a multi-center study, multiple doctors doing it. And guess what? Didn't work. Didn't work. No better than placebo. And the guys who did the investigative report interviewed Dr. Curtis Nickel, and he said he thought it'd be pulled from the market very, very quickly because it didn't work. It was no better than placebo. And yet, look at that. It's still on the market today. And granted, there are patients out there who say it's very helpful for them and they believe that it saved their life. I agree with that. But it didn't fix it because they have to keep taking it. And that's the ultimate tragedy, is that in the end, you just have to take it for the rest of your life. And the more you take it, the greater the risk of eye and apparently bowel issues. So today, we don't want to do that anymore. We want to try to find the underlying cause and treat the underlying cause. If it's estrogen atrophy, let's treat the estrogen atrophy. If it's Hunner's lesions, just treat the Hunner's lesions. If it's pelvic floor, let's treat the pelvic floor. We don't want to give all these patients a bladder med that really has very low chance of actually helping them. There are patients out there who have taken the medication for 30 years now, almost 30 years. 30 years this year. And you ask them, are they better? And they say, well, I feel better, but they still have to take it. So anyway, Robbie said, would L-arginine help with pelvic flares? Great question. L-arginine is a precursor for, is it nitric oxide or something nitric, which is part of the urination cascade that helps the bladder pee. We had research that showed that it helped, and we had other research that showed it didn't do anything. And so the research is incredibly neutral. I honestly, I haven't looked at the L-arginine research. Thank you, nitric oxide. I haven't looked at the L-arginine research recently with respect to IC. To me, the question is, what type of flare is it? Would L-arginine help a pelvic floor flare? Would it relax tight muscles? I don't know. I don't know if it would or not. Would it help estrogen atrophy? No. Would it help a Hunner's lesion? No. At least I don't think it would. And I think the biggest thing to think about with L-arginine is that, especially in the era of COVID, L-arginine actually helps viruses grow, where lysine makes it difficult for viruses to grow. So it's not high on my list as an option anymore. I mean, you're going to find it in quite a few supplements, and I don't see any harm with that. But, you know, if you're prone to viral infections, I would maybe back off a little bit. Yeah, my nose looks big today. Oh, it's always something. It's always something. What else? Is anything else going on? We have the big AUA conference coming up in a month. That's going to be exciting. I'm not going. It's going to be in Washington, D.C., but I will be watching it. I don't have any IC patient events coming up other than these meetings. Yeah, man, we're just, Anne says, yes, it's always something. For me personally, I'm just writing. I just want to write. I feel like we just have to give you guys more and more resources. The more we can do, the better. Yeah. All right. So we've been going for 2.5 hours now. I am happy here to stay here as long as you're here. I can show videos. I'm happy to take questions. I can only show videos on Facebook. I cannot show videos on YouTube. So give me questions. I double dog dare you to try to embarrass me. Please try. I'm always up for a good laugh. Do I have anything else? Obviously, let's see. We're going to be doing some stuff on fitness with IC. We're going to do some stuff with weight loss and IC. I just wrote a big article on weight loss and IC. Robbie said, I hope you had a good Easter. I was alone and kind of sad on Easter, to be quite honest. Easter in our family, number one, it was raining really badly, but number two, we have a whole bunch of kids under the age of 8, and everybody's always sick. There's always colds and flus, and it's very, very frustrating. And so, because I had that really bad super flu and my body is pretty vulnerable right now, I drive up there. I know, well, it was my intention to go, but she just said that they had a new round of colds and flus going around, and I was like, okay, I'm staying home. I was up there this morning. I went up this morning to bring birthday, because they're having a birthday party right now for one of my nephew's kids. So I drove up early and brought up my birthday gifts. I just feel so my body is not as strong as it was since breast cancer. I mean, I'm just so freaking vulnerable to stuff now. I mean, that's why I've had so many visits to the ER, and I just, it's just, my body is not resilient right now. It's just not. And when I get sick, man, I get sick, and then I go into AFib, and then, the blank hits the fan then. Sherry says, are there any supplements I would recommend for pelvic floor? Yeah, this one. And the reason why, I mean, these two. And the reason why is because we want to do everything we can to calm nerves down. And anytime you have pelvic floor dysfunction, you're also going to have muscle squeezing nerves. And so getting a little bit of this on board is, in my opinion, not a bad idea. Do we have a supplement that is a direct skeletal muscle relaxant? No, not that I know of. Anne says, your friend too with breast cancer. Yeah, definitely. And it's funny. I got somebody's tax form in my mail. Somebody sent somebody's tax form to my home accidentally. And I figured out what it was right away. I didn't look at the tax form. I got the name of the accountant, and I called her. She was just less than a mile away or 2 miles away. And I said, hey, you just sent somebody's tax form to my house. You want me to bring it back to you? And I promise you I haven't looked at it. And I did not. I would never do that. And so she came over, and we just had a great conversation. And it turns out she had a double mastectomy like 3 years ago. It's like, so I always think the Lord works in mysterious ways and puts people together. I also think too, and this is really, really true in the IC Network shop, if there's a problem with somebody's order, let's say they get the wrong thing or it gets lost in the mail or something like that, and people call to complain, and I talk to them, and like 9 times out of 10, like there's a really important reason why we needed to have that conversation. And I always try to apologize for mistakes by just trying to help them a little bit. And those are all usually really, really meaningful conversations. And it's really rare that anybody's ever really mad at me for something. I try to make it right with everybody. Believe me. But, Postal Service is bonky right now. I mean, so many packages are being lost. It's ridiculous. And we will have tracking showing it makes it across the country to their local post office, and then it disappears. Robbie says, the Lord blessed me when I found this broadcast and your advice. Thank you, honey. Thank you. I try. It's the only thing, it's the only way I can justify my life is, why did God give me so much pain when I was younger, if not to use it to help others? Kathy says, my feet swell. Is there any way this is related to anything with IC? No, I don't think so. What that means probably is that you're retaining water. It might relate to your kidney function, or it could even relate to your heart. I mean, you definitely need to talk to your doctor about that. They might want to do a few additional tests, just to try to figure that out. If you're eating a lot of salt, that would do it. Like, here's the other thing about getting older, my friends, is like, got to cut the salt, and then you got to cut the sugar, and then you got to cut the saturated fats, and then you got to cut this, and you got to cut that as your body changes and gets older. And one of the things that women experience with menopause is that one of the unanticipated side effects of menopause is that your body starts to struggle processing salt. And what does that mean then? High blood pressure. And like 50% of postmenopausal women have high blood pressure. I have high blood pressure. Shocked the blank out of me. I was stunned when they told me I had high blood pressure. It's 150 over 100. Now it's I'm on 2 meds, and it's like 135 over 82, and that's a win. I'll take it. but the things that happen when you're over 60 are just strange. All right. So thank you, you guys. Thank you, Sherry. That was very, very sweet. Kathy says, me too, because doctor never helped, no information, you stop going. Well, I understand that, because healthcare right now is like being in a factory. You just want a doctor who knows you, who believes you, and who will see you when you need help or reassurance. And I'm part of Kaiser Permanente, and I've been a Kaiser member for 30 years. And listen, they've saved my life. I've had excellent surgeries with Kaiser, but you don't get to see your primary care provider. Like, you have to beg and then wait for months praying that an appointment will open up. And that's just not Kaiser. That's everywhere now. It's really rare that you find somebody who has a good relationship, long-term relationship with a primary care provider where they really feel like they're cared for. And that's healthcare today in the United States. And that's something we need to be changing. Because in the end, it's all about the money, honey. In the end, it's the health insurance companies that are screwing us all. And reimbursement rates. And you realize back in the 50s and the 60s, doctors were like anybody else. They made a modest wage. Some of them got paid with chocolate chip cookies. Some of them got paid with chickens. Mostly they got paid with money, but they weren't millionaires. They weren't millionaires. And today, doctors, to become a doctor, you're talking massive medical loans. I mean, student loans, $300,000-$400,000 just to become a doctor. And that's why we're having such a hard time getting new doctors, because they can't afford to go to school anymore. And then for the ones who are already doctors and trying to pay off their bills, the insurance companies aren't reimbursing them. God forbid you live in Florida. Florida has the worst reimbursement rates in the country. That's why it's so hard to find good doctors in Florida, because they leave. I feel like it would be really nice if we could just go back to a cash in hand relationship with our doctor and just have insurance for emergencies. Isn't that the way that it used to be? I would love to have a good relationship with my doctor. I think she likes me, but I don't get to see. I think I've seen her twice in 5 years. Even as a cancer patient, I did go see another surgeon for my incisions, because I'm telling you, my post-op pain is off the charts. I'm like in the top 2% for post-op pain. And you see me, I'm usually sitting here rubbing these incisions because they freaking hurt. They're tight. They're just tight. And I did go see another surgeon who did another very thorough exam. It's not cancer. It's just, it's nerve damage. So anyway, Kathy says she agrees. Robbie says, I make appointments when I don't even need them, because it's so much easier to cancel an appointment than to get one. That's a good theory. You know what? Like, just 3 times a year, make an appointment. Or 4 times a year, once a quarter, make an appointment. You can always cancel it, just in case. That's a great idea. Of course, the problem with Kaiser is they only open up 1 month of appointments at a time. And then you have to wait for them to open up the next month. And then they get filled so quickly, they'll be filled in 24 hours. So then it's like, You want, okay, give me an appointment the third month, and they'll say, well, we haven't opened up those appointments yet. So it's, I mean, this is why I think Amazon now has that urgent care clinic where you can go in and pay. Man, that's a win. That's a win in my book. Because we've lost the primary care model, and now we're in emergency room, urgent care situation where you just don't get the care for a cold or a flu. So you go to urgent care, or if you're having trouble breathing, you go right to the ER. I was at the ER yesterday with a friend. Again, not for me, it was for somebody else. But Robbie, that's a really good idea. All right, my friends. Well, I think we have come to the natural end of this meeting because I think y'all are tired. Yeah, I think you're tired. I think we're done. It's dinner time back east. It's almost 4 o'clock here. So last call for questions. Last call for questions. And if you find, and for those of you watching, if you've been listening for 2 hours, thank you. Thank you for holding on. Appreciate it. IC Network Shop is open. If you need any of the supplements, anything at all like that, if you want to become a member, get our IC Diet Guide or IC Flare Guide or our book, IC 101, It's Not Just a Bladder Disease. You can get all those over on the IC Network. And also, just so you know, I do wellness coaching for patients who are just not getting anywhere. If you want to spend a lot of time and going over your history and all that sort of stuff, I'm happy to do that with you. You can sign up for wellness coaching. In the IC Network office, the patients who get priority are the patients who sign up for coaching first. And then once I'm done with that, then I do phones, regular phones. Hey, Sherry, I haven't seen you, girl. You were very quiet. How you doing? How are you doing? Hey, Danielle, how are you, hun? Thank you. It's nice to see you too. Hope life is treating you well. God knows we're living in chaotic times right now, so we all just need to find our calm and center, turn off social media, turn off the news, and just be good to the people around us, you know? Sherry, you're still struggling with your pelvic pain? Yeah. Well, you know, your case is pretty complex. Your case is very complex. Have you considered any more thoughts on, didn't they at one point in time suggest you having surgery for scar tissue? Sharon says, any advice for pelvic floor tightness? Yes. Number one, we want to go to a physical therapist, and we want to make sure we know what's tight, because there are lots of different muscles down there. It can be on the left side, it can be on the right side, it can be both sides, it can be shallow, it can be mid-level, it can be deep. So we kind of just want to know the anatomy a little bit more, and having a proper pelvic floor assessment is very, very helpful so that you know the names of the muscles that are your problem. Then you could use a wand internally to just massage that muscle and relax. You could take a hot shower, a hot bath. Heat helps muscles relax. You can do a variety of stretches and exercises, which you can find right here in our Flare Guide, that will walk you through things you can do to try to nip that flare in the bud. You could use a muscle relaxant to relax those muscles, a skeletal muscle relaxant like baclofen or Flexeril. You could do some massage. You could do some deep breathing, which relaxes muscles. Lots and lots of options for patients in a pelvic floor flare. But in the end, we want to try to understand, why are your muscles tight in the first place? As an example, so remember, 87% of IC patients have tight pelvic floor muscles, and there's a dangerous legacy to tight pelvic floor muscles. It's called ischemia or ischemia. What that means is that the muscles are so tight, they're now restricting blood supply. They're restricting blood supply to the bladder, to the vulva, to the rectum. So so is your bladder going to be healthy if it's only getting half of the blood it needs? If it's being deprived of essential oxygen and nutrition, is it going to be healthy? And the answer, of course, is no, it's not. And so it's very, very important that we not live in a constant state of pelvic floor tension, because over time that can lead to more damage. We want to restore a blood supply. Our therapeutic priority is to restore a blood supply so that we can get good oxygenation to that tissue. Hold on. So you don't want to be passive, you want to be pretty active. So let's say you go to a physical therapist, you have a proper pelvic floor assessment, great. They tell you it's your levator ani, great. Now we know what it is. The physical therapist is giving you some stretches to do. You're going to go back to physical therapy. She's going to do some internal massage, really work on those muscles. And it's all about internal massage. It's not about biofeedback. It's not about using a wand at the doctor's office. It's about a finger touching those muscles. A healthy muscle feels like a raw chicken breast. It's soft, but it has substance. A tight muscle feels like an overcooked rubber chicken breast. And a badly damaged muscle feels like beef jerky. And so the best way to manipulate these muscles is with a finger massaging the muscle. And it's very easy to do. And usually a tight muscle will relax and release very, very quickly within a couple of minutes if you do internal massage. So don't be afraid of that internal massage. It's really, really, really helpful. I've had it done many times. But the question I want you to ask that physical therapist is, after 3 or 4 visits, is, are my muscles responding, or are they always locking back down into tension? Because if your muscles are always locking back down into tension, no matter what you do, that's important. We've got to figure that out. Because what that then means is that we probably have a problem with a bone. Because what puts stress on muscles but bones? So for example, you could have one leg higher than the other, which would tilt your pelvis to one side. You could have a bad hip. You could have a hip that's rotated. You could have an SI joint that's too flexible. Or if you have a bad knee and you're limping, every time you limp, you're stressing your pelvic floor. But it turns out one of the most common causes of long-term chronic pelvic floor tension is actually your feet. It's how your foot hits the ground. If you have an ankle that rolls in, that's going to stretch your pelvic floor. It's going to stretch your pelvic floor out on that side. And let me show you a picture. Let me see if I can find it right away. You'd think I'd have a Post-it on it, but it usually opens up right to it. Okay, hold on. I'm going to find this. I swear I'm going to find this. Okay, I got to go to the foot chapter. Hold on. Not treatment strategies for PNE or the pudendal nerve. Here it is. Okay. So I want you to look at this real quick. This is a great, great picture. So on this side, this is a normal straight leg and pelvic floor. So look, you can see the piriformis muscle right here. You can see that the ankle hits the ground at a 90-degree angle, right? So that's a good, healthy leg. Now look at what happens when you have an ankle that rolls in. So the very first thing that happens is we've lost our 90 degrees. Now we have a leg that's tilting to the far side. And that gets exaggerated up in the femur. And look what it does up to the piriformis muscle. You see that? So here's the healthy one right here. Here's the stretched out one. It's stretched out like 40% more. That's long-term pelvic floor tension on that side, just from the ankle rolling in. Is that not cool to see it like that so easily? But you can also have Morton's toe. So with Morton's toe, the second toe is longer than the big toe. So here's the problem. The way the foot and the body is created is the bigger the toe, the more weight it's meant to carry. So in a normal foot, the big toe hits the ground first and carries 90% of the weight. And then the second toe carries the other 10%, and these toes do nothing. They're just balancing. But when the second toe is bigger than the big toe, the second toe hits the ground first. And so now the big toe gets bypassed. Big toe doesn't do much of anything. All the weight goes here, and then it gets spread here. And so, hammer toe, when the toe bends down like this, that's that toe compensating for all of the weight that it's carrying. And so this also is a very common cause of long-term pelvic floor tension, is how your foot hits the ground like this. And this is a really easy fix. You can just put a very simple pad, a toe pad, like right here, right underneath the knuckle of the big toe, which is what I do on my right shoe. And just a little piece of moleskin. And it's just enough to make sure that the big toe hits the ground first. And then that stops that whole process. So how your foot hits the ground really matters. So one client of mine who had watched one of these meetings, terrible pelvic floor dysfunction, just terrible pelvic floor. She'd been in physical therapy. It hadn't worked for her at all. She just was in so much pain with her pelvic floor. It was always tight. So she called just shortly after this book came out, and I said, "How are your feet?" And she paused for a moment, and she said, "I have club feet. I was born without toes." That's why she has pelvic floor dysfunction, because she's never walked normally. She's never been able to walk normally, and that foot abnormality has affected her muscles tremendously. So again, at appointment 3 or 4, ask your physical therapist, are my muscles responding, or are they always locking back down into tension? If your muscles are always locking back down into tension, we have to look at bones, especially your feet. And you're going to have to start investing in really good shoes. And so, here, hold on. My shoes are Hoka's. Hoka Bondis are just, I have like 4 pairs of them. They're so good. So anyway, hopefully that answers your pelvic floor question. Danielle says, I'm hanging in. You had endometriosis on your hospital records, so much I needed to tell you. And yes, my pelvic floor is really bad, but looking into an HFX machine implant because the pain is so much worse. Okay. You call me, hon. We should talk. You have L4, L5, back starting to deteriorate. That was what your MRI found. Yeah. And I had new x-rays and my scoliosis has gotten worse. And I'm so freaking annoyed with that myself. I do not want to have spinal surgery. Please, God, no. But it's getting close. Kelly says, can a cystitis cause very tight pelvic floor muscles? I'm starting physical therapy on Thursday and hope that it will help the muscles relax. I do not have a PESR yet. I'm still thinking about it. Well, isn't that, Kelly, that's a great question. And you're kind of in a damned if you do, damned if you don't situation. Because generally, there are kind of 2 scenarios here with a cystocele. A cystocele basically means that the bladder is starting to fall. So the question is why? Well, concept number 1 is that we're dealing with muscle weakness. When the pelvic floor muscles get weak, when different things start to get weak, things start to fall. And so whether it's a cystocele or a rectocele or whatever kind of seal you've got, generally we're looking at muscle weakness as the underlying cause of that. And if you catch it early enough, physical therapy could stop it. But there comes a point in time when the muscles just stretch out too much, and physical therapy won't fix it anymore. And that's when we go to a pessary, which, as you know, you have one. You stick it in your vagina, a lot of different shapes, and it kind of holds things in place. And then at some point in time, depending upon how severe it is, surgery is usually the best treatment, because the muscles are stretched out and just, are not going to be as responsive to physical therapy. So kind of concept number one is, it's really good you're going to physical therapy. Do it. Absolutely do it, because you need more insight into what's going on with your muscles. So having a proper pelvic floor physical assessment, preferably by a physical therapist who's fully certified in pelvic floor work, is an absolute must for you, because we just need to understand, you just need to understand your overall muscle health right now. You're hearing me hesitate because you're going, if it will help your muscles relax. And we don't necessarily want them to relax so much that your cystocele gets worse. We want to strengthen them. So kind of a likely scenario is that there is an old injury, let's just say from childbirth. Let's say you had a couple of rough deliveries, your pelvic floor muscles got stretched and loose, weakened, injured. Those muscles still have a job to do. And so what happens when a muscle is weak, it overcompensates. So it starts to get really tight. So often tight muscles are a sign of weak muscles. And so the physical therapist has to do two separate things. Number one, we have to reduce the tension. And then once we get rid of the tightness, then we have to strengthen. We have to strengthen the weak muscles. And that's exactly what they found with me, is that my pelvic floor muscles were really, really tight down at the lowest level. My levator ani muscle, these muscles were very, very tight because they were compensating for very weak piriformis muscles, deeper muscles. And so there are a couple of different things that have to happen potentially to really work on what's happening with you. So again, having a proper, fully certified pelvic floor physical therapist is critical. You don't want to go to somebody who specializes in incontinence, because all they're going to do is tell you to do Kegels. That doesn't fix this, and it can make it worse. Part of it worse. So I would recommend that you go to, there's a great website, pelvicrehab.com. This is the website I use. I'm putting it in there. Pelvicrehab.com is a database of physical therapists certified by the Herman Wallace Institute. You can search it by zip code. Look there, and let's see if the physical therapist they've referred you to is certified. Hopefully they are. If not, you could potentially ask if you can see somebody else. But their goal at that first appointment is to just give you an assessment of your muscle. They need to do an internal exam. They need to touch muscles, left side, right side, shallow, deep, and let's just see what's going on there. Because right now, we just don't know what's going on there. Clearly, something's happening, though, because you have a cystocele. So, and you're thinking about getting a pessary. It's not a bad idea. A lot of young women who are athletes, especially distance runners, their running has really badly affected their pelvic floor, so they have to compete with a pessary. Pessaries are annoying at times. Finding the right one that fits your body is the biggest challenge. Again, they come in lots of shapes, lots of sizes. You just got to have an open mind and be willing to try stuff. I'm going to share one story with you because I think that this is one of the most important patients that I've ever worked with. This was a lady who contacted me probably in her early 70s, and she had a cystocele, and she had a pessary. And she did not want to have surgery back then. And the doctor said, you really need to have surgery. And she's like, no, I just want to do the pessary. Well, that became the biggest regret of her life. And I can tell you that because I worked with her for probably 20 years before she died. And so what happened over that time is that even with the pessary, her muscles just got weaker and weaker and weaker until at the end, literally things were hanging out between her legs and she could not walk. I mean, and this was the sweetest, nicest elderly lady ever. I adored her. And so she finally, at like 85, she's like, all right, give me the surgery. And they said, you're too old. You're too old. And every single time I talked with her, every single time she said, I regret not having the surgery when I could have, when I was younger. And I will tell you that she suffered tremendously in her, she ended up moving from California back east, and then I stopped hearing from her. I'm pretty sure she died during COVID. She was probably in her 90s, early 90s by then. And I will never forget that because that taught me a really important lesson. And that is that if you're going to have surgery, you want to have it when you're younger. You don't want to wait and wait and wait because you might get to the point where it's too late. Like my dad had a hernia, which we finally found when he was 100 freaking years old. And I begged them to do the surgery and they said he won't survive. And you know what? He didn't. He didn't even survive the test. He had a heart attack. And one of the reasons why I opted to have a double mastectomy last year or in 2004, I only had breast cancer in one breast, but I was 64. I'm like, do it now. Take them both. I don't want to, because it's very common for breast cancer to be found in the next breast 5, 6, 7 years later. I didn't want to have surgery when I was 70 or 75, as many elderly women diagnosed with breast cancer have, even 80, 85. I'm like, man, take them now. No regrets. No regrets. And now I'm contemplating spinal surgery potentially. And it's like, man, I don't want to wait until I'm 70 to do that. If I'm going to do that, I'll do that in the next year or two for sure. So that's my thought on that. Danielle says, during COVID, I had a triple prolapse. All 3 went down since the last time we spoke. I was diagnosed in my records. Wow. Girl. Yeah, Nicola says, just came on. How do we buy your book? Over on our website. Here's the link. You can get them right there. Our flare guide is $16.95. Our diet guide is $18.95. I will tell you it costs $11 to print each one, so it's not like we're making a ton of money here. We are not. All right, guys. Well, we've been doing it for 3 hours. Well, Danielle, it is what it is. Life is just unpredictable. That's why I'm very, very invested on staying as thin as I can be, because I know I do not want to carry any heavy weight on this scoliosis. That's for sure. Tanya says, my primary says after 75, no need for mammograms. I don't know about that. Typical Florida doctors. You know why they say that? Is because breast cancer is slow growing and they think you're going to die first before it affects you. Robbie says, can you get a signed copy Yeah, sure. Darn it. I was just up in the warehouse. I could have done that for you. If you place the call me on Monday or Tuesday. I mean, call me on Tuesday or Wednesday. Guys, I'm not so good on Mondays. I'm usually pretty tired and my voice is really affected by doing this meeting. So, I mean, you're welcome to call me tomorrow. I can't tell you if my voice is going to be real good. Tuesday and Wednesday, I'm on. Tuesday through Friday, I'm good. Hey, Kayleen, long time no see, girl. I hope you're doing well. So, Robbie, call me, and what I'll have to do is I'll have to get a new copy of it, and it might not be right away. It might be in a week or two, but I think I can make that happen. Hi, Jane. How are you, hun? Kayleen, what's going on, girl? How's your life? I was thinking about you the other day, hoping you were doing okay. Say hi to your mom for me. You're in the ER for a girl. Holy crap. You're in the emergency room right now for a GI bleed. Oh my God. Is it really severe or is it minor? Oh man, any idea what caused that? You have been through it? My God, woman. All right, guys. So I'm here as long as you have questions. We're kind of at the tail end of the meeting, but I'm happy to stick it out. If you got questions and want to talk about stuff, feel free. If not, well, I'll go make dinner. Kayleen said you went to a bad ER in Rockford last night, tested positive for the GI bleed. Obviously, they sent me home, so I drove to Chicago today in pain. Yikes. Good luck. Keep me posted. Text me and let me know what they find, okay? Driving was a no-no. Girl, I haven't seen you. So so we had a week of 100-degree weather. We've never had that in March before, and I went for it. I loved it. I do not like the cold, just like you. I like the heat. And so I just doing a lot of stuff outside in the sun, enjoying myself. I got massively dehydrated. And I ended up in severe tachycardia. This was 2 weeks ago. Like, I'm an idiot. I mean, I'm just an idiot. I say that, I mean, I'm not an idiot. I know I'm not an idiot. I was just so craving the sunshine and the heat. I just forgot to drink. So anyway, I went into tachycardia, as I do. So I drove myself to the ER. You know, I mean, I don't wait now. I mean, if I'm in severe tachycardia, I just get in my car and go. So, I mean, within 45 minutes, I was at the ER because you know when it's bad. And my heart rate was 150. And they just plopped me in a wheelchair, took me right back to the heart unit. It's like, get back there. No waiting room for you. Just get back there. And we did the blood testing and my potassium was really low. And that was because I was dehydrated. There's a little bit more to that story. Anyway, when I got there, they went, "You drove?" I was like, "Well, there wasn't anybody else to drive me. Of course they drove." She goes, "You could have passed out in the car." And I'm like, "I've done this at least 10 times in the last 3 years. I've never even gotten dizzy before. Oh, you've had black mucus. Yeah, you got something going on, girl. They got to figure that out. Yikes. I'm all better now. I mean, they gave me potassium, which fried my bladder for a couple days, but I am better. And now listen, this is still my first one of the day and it's 4:00, so I'm behind. I mean, I already drank basically half of one of these, but I'm a little behind myself. Tanya said, I've run low potassium for decades. I have to take potassium pills daily. Probably not good for my bladder. Yeah, potassium is really well known for potentially irritating the bladder. Danielle said, oh my God, 100 degrees. Ugh, I'm a cold weather person because I'm estrogen dominant and hot all the time. It's awful. The summer kills me. I'm in the air conditioning all day. Danielle, I'm exactly the opposite of you. And again, this all happened after losing my breath. I don't have, I mean, like I'm just flat. You see this? There's no fat there anymore. And thankfully the rest of my fat is slowly shrinking. And so I don't have that fat layer anymore. So I'm always cold. And you know, I'm always wearing polar fleece, even in the summer. Like all last summer, I was wearing polar fleece like it was winter. And so the only time I get warm is when it's like 100 degrees. So I want it to be hot. I will never retire to cold weather. I can't do it. I just don't have the protection anymore. And this is why I keep wearing my dad's vest, you know? It's crazy. Danielle says, I flare so bad that I'm up peeing every 15 minutes last night. I tried not to drink water because it makes me feel like worse, but I know that's not true. I just try to keep my water intake as high. Yeah, it's tricky because it feels like your bladder wall, but remember, a lot of those flares are actually from your pelvic floor. Ugh. Tanya says, but does California have the bad humidity like Florida? No. We are a dry heat, thank God. I've only been to Florida once and I loved it, but it was only maybe 80 degrees. I can't imagine. I will tell you that I spent a summer teaching tennis at Choate Prep School up in Wallingford, Connecticut, where it's very, very humid. And I remember one day I went out running. I ran like 3 or 4 miles on a hot day and I couldn't sweat. I wasn't sweating. And that's really dangerous. And so, you know, I turned around and ran back. You know, I was 19 years old. I didn't have an ounce of sense in my body. And I could see that I wasn't sweating when I should have been sweating, which is a real sign of heat stroke. And so I went into, it was dinner time. And so I was teaching at a tennis camp. It was a summer tennis camp. And so everybody was eating. So I went in to eat and I remember sitting there and then all of a sudden it all burst out of me. I was just sweating out of every pore. It was crazy. So I have been in super, super humid weather, but I'm a California girl, born, bred. I am just a California girl. If I go anywhere, it would be Arizona. Although honestly, I really loved Florida when I was there. The place I didn't really like, believe it or not, was Hawaii. I've been there a couple of times because I have family that live there that were in the Navy, but I don't know. Kayleen said it was a crime scene yesterday before you went. Yeah. It's been raining and windy, but we're finally staying in the 70s. Good. It's cold here. We've had a lot of thunder and lightning for the last 3 days. So we're now back down in the 50s. But that 2-week period of hundreds and 90s was glorious. And I was very, very happy. Very, very, very happy. The other really good thing that happened is BTS is now doing their concerts. So I was up at 3 in the morning watching the BTS concert. That makes me very happy. Life is weird. Anyway. All right, guys. Well, I think that we've come to the natural end of our meeting. So my intention is to be here next Sunday. I am always available by phone. Please feel free to call me. Again, if I respond with, I can't talk right now, or can I call you later? It just means I'm already working with somebody. Just be patient. You can be the squeaky wheel. You can call me back. It's okay. It's not a problem. All right. So thank you for watching, everybody. We'll see you again. I truly hope that you have a fantastic week. Let us hope that the world calms itself down and we can all sleep comfortably without stress, because times are pretty stressed, and financially too. I mean, I just filled my car up. You know how much gas was out here? $6.40. It's crazy time. All right. I'm going to say goodbye to YouTube. Bye, YouTube. See you later.